surgery GIT, and it will be taken by our very own faculty, Dr. Rajeev Tewari. Well, I hope everything is going very well. You people are really wonderful, giving us energy all day, every day. It's your zeal, as I said, which is making us work tirelessly here. And this event, the DAMS DVT, has become India's biggest medical PG prep academic event. Thanks from the bottom of our heart to all of you people. Let's continue with learning, as it is always said that continuous improvement is better than delayed perfection. Our next session is surgery GIT. As I mentioned, will be taken by Dr. Rajeev Tewari. Dr. Rajeev Tewari has done his MBBS from KGMC Lucknow. He has done his MS from KGMC Lucknow, and he has worked in Safdarjung Hospital, Maulana Azad Medical College, Hindu Rao Hospital, Balaji Action Medical Institute, Apollo Hospital as consultant surgeon. He has been teaching in DAMS Medicos for the last 24 years. Wow, probably experienced more than the age of some of our students probably. Well, he loves every moment in DAMS Medicos teaching all the young and wonderful people, and he really feels glad to see his students doing well in life. So let's keep on learning, because tomorrow belongs to those who prepare for it today. Apna time apun khud laega. So let's get started with surgery GIT through our esteemed faculty, Dr. Rajeev Tewari. Over to you, sir.
Good afternoon, everyone. तो चलो शुरू करते हैं. देखो, my session is 2 hours, and unlike other faculty, I'll finish in 2 hours. So हम सारे important point discuss करेंगे. It's more of a revision. जो हमने whatever we have discussed in regular batch, it's more of a revision. We'll go a little fast because I'm sure you all of you know. आपने पढ़ा हुआ है, you have read this, so it won't take much time. So I'll start with hernia. Hernia is a very, very important topic. My advice to all of you: read hernia anatomy and surgery and classification very thoroughly, because every year I see question from hernia. Hernia was not important 3-4 years back, but believe me, last 2-3 years, like this very year, we had 3 questions from hernia in NEET, 1 question in inicet in June, 1 question last month. So in this very year, I have seen 5 questions from hernia in inicet and NEET only. Forget other exams. So hernia is very important. Read hernia very thoroughly. In hernia, I'll only tell you, I cannot discuss anatomy, etc. We don't have that much time, but I'll tell you the basics. I'll tell you a very important thing: triangle of doom and triangle of pain, and the content, and myopaternal orifice of Fouchard, which frequently they ask. So this, and the nerve injury. So this is something new. You have to listen carefully. Before that, we will discuss the Nahes classification. Dekho, we all know the basic anatomy of hernia, like this is ASIS, this is the inguinal ligament, and this is pubic tubercle. Okay, this is the rectus muscle. The posterior most layer anterior to peritoneum is fascia transversalis. So there is a defect in fascia 1.25 centimeter above midpoint of inguinal ligament. Listen carefully. The inguinal ligament midpoint is called midpoint of inguinal ligament. But if I draw a line from ASIS to pubic symphysis, this is called mid-inguinal point. So the red point is mid-inguinal point and the blue point is midpoint of inguinal ligament. Deep ring or internal ring, I want you to remember 2 lines. First, it's in relation to midpoint of inguinal ligament, in relation to this. This. So this is in relation to midpoint of inguinal ligament, not mid-inguinal point. And number 2, it is a defect in fascia transversalis, which is a this year question. This very year we had a question in NEET. They showed a photo with a arrow pointing at the deep ring, and the question was, this defect is in which structure? So remember, the deep ring is a defect in fascia transversalis, 1.25 centimeter above midpoint of inguinal ligament. And this is the inferior epigastric artery. Indirect hernia comes out from here, IH, indirect, direct hernia comes out from here. So in terminology, what we say, indirect hernia is a defect in deep ring, wide deep ring. So whenever you say wide deep ring, by default we mean indirect hernia. And direct hernia comes out from this triangle, Hasselbalch's triangle, bounded by inferior epigastric artery, rectus, and inguinal ligament. So when I say posterior wall is weak or fascia is weak, it means direct hernia. So rather than saying indirect and direct hernia, the terminology we use for indirect hernia, we say deep ring is wide. For direct hernia, we say posterior wall is weak. Okay? So I'll just repeat what I said. The deep ring is a defect, or internal ring is a defect in fascia transversalis, 1.25 centimeter above midpoint of inguinal ligament. Indirect hernia comes out from the deep ring here, and direct hernia comes out from this area, Hasselbalch's triangle. Eventually, finally, both, this is the deep ring, this is the superficial ring. Superficial ring is a defect in external oblique. Both will, whether it's coming out from here or coming out from here, both will come out from the external ring. So once we have understood the terminology, let's understand the classification. Dekho, Nahes type 1 and type 2, both are indirect hernia. So because they are indirect hernia, they come out from the internal ring. The posterior wall or fascia will be normal. What's the difference in type 1 and type 2? Type 1 is a defect where the internal ring is normal. Type 2 is a defect where the internal ring is wide. So type 1 and type 2 both are indirect hernia in Nahes. Type 1, the deep ring is normal. In type 2, the deep ring is wide. And in both, the posterior wall will be normal because they are indirect hernia, not direct hernia. So posterior wall or the fascia is normal. The deep ring is normal in type 1 and it's wide in type 2. Both are indirect hernia. Type 3A is a direct hernia. And how we define direct hernia? The posterior wall will be weak, the fascia will be weak, while the internal ring will be normal. So only the posterior wall is defective or the fascia is weak, but internal ring is normal because it's a direct hernia. Type 3B is direct and indirect both, which is called pantaloon hernia. So you have a question like pantaloon hernia is which type? Pantaloon hernia is type 3B Nahes, where the posterior wall will be weak because it's a direct and internal ring is wide because it's indirect as well. So type 3B is direct and indirect both, which is pantaloon, and type 3C is femoral hernia. Now I want to remember three lines. Number 1, congenital hernia type 1, type 3B pantaloon, type 3C femoral hernia. This is what they ask. Just to revise it once more, and type 4 is recurrent hernia. Just to revise once more, type 1 and type 2 are indirect hernia. Type 1, the posterior wall is normal. Type 2, the posterior wall of fascia is normal. In type 1, the internal ring is normal. In type 2, the internal ring is wide. Type 1 is called congenital hernia. Type 2 is a normal indirect inguinal hernia. Type 3A is a direct hernia, where the posterior wall is weak, but the internal ring is normal. Type 3B is a direct and indirect both. So posterior wall is weak and internal ring is wide. That's called pantaloon hernia, and type 3 is femoral. So Nahes is one classification that they do ask frequently. Okay. Now let's come to the laparoscopic hernia triangle. Dekho. If I draw the laparoscopic from inside, not from outside, the anatomy we discussed from outside. Now we are looking from the abdomen, inside. This is ASIS. This is the inguinal, from inside. It's the right area from inside, from the abdomen view. This is the inguinal ligament. This is the pubic bone. This is the rectus muscle. And this is the psoas. So I am writing PSOAS. And this is the peritoneum covering the psoas. Okay? Look carefully. This is the vas, so this is the external iliac artery here. This is the external iliac vein here, and this is the femoral nerve here. This will become femoral artery and vein once it goes below the inguinal ligament. We are in the, not in the thigh, we are in the abdomen. So it is external iliac artery and vein. Now this is a internal ring and vas deferens. This is the testicular artery, and this area is called triangle of Doom. Let's see here. Triangle of doom boundaries are testicular artery, which can very well be called as spermatic artery or gonadal artery. So gonadal artery and testicular artery or interspermatic artery are same. So one side is gonadal artery, one side is vas deferens, and one side is peritoneum covering the vas. This triangle is called triangle of doom. So what are the boundaries of triangle of doom? Vas deferens, testicular artery or gonadal artery, and peritoneum. What are the content? You can see here. The contents are external iliac artery and vein. Can we do dissection here? Can we fix tacker here? Can we fix mesh here? Of course not. If I do dissection, if I put tacker, if I put anchor, we will have very torrential bleeding. So which is why this is called triangle of doom. So what are the content of triangle of doom? External iliac vein and artery. This and this. Okay? This and this. Plus one nerve. Genital branch of genitofemoral nerve. So one nerve also is there. So the boundaries of triangle of doom are external vas deferens, testicular artery, and peritoneum, and the content are external iliac artery, vein, and genital branch of genitofemoral nerve. Lateral to this artery is another triangle, this, another triangle, this, and this. This triangle is called triangle of pain. Why triangle of pain? Let's understand the boundary. It has two same boundary. One is the testicular artery. Previously also we had testicular artery, one boundary. One is peritoneum. Again we had peritoneum. This line is inguinal ligament, but from inside we call it iliopubic tract. So triangle of pain boundaries are testicular artery, peritoneum, and iliopubic tract. Why we call it triangle of pain? We have very important nerves here, 4 nerves here, lateral to medial. Lateral cutaneous nerve of thigh, anterior cutaneous nerve, femoral branch of genitofemoral nerve, and femoral nerve. Let's see here. So this is the boundary of triangle of pain. Testicular artery, peritoneum, and iliopubic tract. This is the boundary of triangle of doom. Testicular artery, peritoneum, and vas deferens. So in triangle of P and D, D is doom. Let's write with black color. D is triangle of doom. P is triangle of pain. Together, this is called trapezoid of disaster. Together. So, what are the nerves? Lateral cutaneous nerve of thigh. Most commonly injured nerve in laparoscopic hernia surgery. This is a 2023 NEET question. So, 2 questions I told you which were asked in March 2023 this year, NEET. One was a defect in the deep fascia, the arrow showing the deep ring and asking in which structure the defect is. That was a defect in fascia transversalis. And second was which is the most commonly injured nerve in laparoscopic hernia. Write down these 3. It's not written here, you have to write it down. Most commonly nerve injured in appendix, open appendix surgery is iliohypogastric nerve. Only the nerve gets injured when we make a incision muscle cutting, not muscle splitting. So grid array incision has no risk, Lance has no risk, but Rutherford-Morrison incision, which is a muscle cutting incision of appendix, one can injure which nerve? Iliohypogastric nerve. In open hernia surgery, which nerve gets injured? Ilioinguinal nerve. So see, this is the abdomen. If I'm operating appendix, I make incision here and the nerve injured is iliohypogastric. If I'm operating hernia, I make incision here and the nerve injured will be ilioinguinal. Another question that they ask that after hernia surgery, patient has anesthesia or paresthesia or altered sensation or hyperesthesia at the root of penis or medial aspect of thigh, which nerve gets injured, has gotten injured, and that is ilioinguinal nerve. So in hernia, ilioinguinal nerve is injured, causing anesthesia or paresthesia at the root of penis and medial aspect of thigh, and in open appendix, iliohypogastric nerve is injured. While in laparoscopic hernia, which nerve is injured? Lateral cutaneous nerve of thigh. This line is called iliopubic tract. No tacker or anchor or fixator or dissection is done inferior and lateral to ilioinguinal nerve because you will damage triangle of doom and pain once you go inferior and lateral to ilioinguinal nerve, iliopubic tract. Okay, this line is iliopubic tract. This line. So the lateral nerve is lateral cutaneous nerve of thigh, most commonly injured nerve. Then anterior cutaneous nerve. Then femoral branch of genitofemoral nerve, and finally femoral nerve. So lateral to medial 4 nerves are lateral cutaneous nerve of thigh, anterior cutaneous nerve, femoral branch of genitofemoral nerve, and femoral nerve. Let me show you. देखो, ये here, a nerve is coming called genitofemoral nerve. This will give a femoral branch and a genital branch. Where the let's use green color. A femoral branch and a genital branch. Where the genital branch is going, it is going into the internal ring, deep ring. So genital branch becomes a content of triangle of Doom. This is the genital branch, and this is the genital. And femoral branch becomes a content of triangle of pain. So genitofemoral nerve will divide into 2 branches. Femoral will go laterally, becoming a content of triangle of pain, and genital branch will come medially, going into the internal ring, going to testis, becoming content of triangle of Doom. So content, so let's revise one more time, last time, then I'll move on to myoperitoneal short. What are the boundaries of triangle of Doom? Vas deferens, testicular artery, and peritoneum. And what are the content? External iliac artery, external iliac vein, and genital branch and genitofemoral nerve. What are the boundaries of triangle of pain? Testicular artery, peritoneum, and iliopubic tract. And what 4 nerves are there? Lateral cutaneous nerve of thigh, anterior cutaneous nerve, femoral branch genitofemoral nerve, and femoral nerve. And most commonly injured nerve, this one, which is lateral cutaneous nerve of thigh. Okay? So, this is about the nerve injury and triangle. And together both triangles are called trapezoid of disaster. Now, if you look here, this is the area, this is the deep ring, this is the Hasselbalch triangle, this is the femoral triangle. So, this area shown by violet color needs to be reinforced. This is where we have to put the mesh. Although the mesh will cover this area as well, mesh will cover the green area as well, but we don't do any fixation there. You know the reason. Triangular doom and pain. So, only this area needs fixation, this area. This is called myopectineal orifice of Frouchot. Frouchot, it's pronounced French Frouchot, but in English we can call it Frouchot, so remember the spelling. So, myopectineal orifice of Frouchot, what are the boundaries? Let's see. Very simple. ये देखो, ये है laparoscopic view, the vas deferens, testicular artery, and peritoneum. So, what is this? Triangle of Doom. And this is the testicular artery, iliopubic tract, and peritoneum. This is triangle of pain from inside. Okay. Now, this is the myopectineal orifice of Frouchot. Now, you see, yes, Shweta, you are right. In appendix, it's iliohypogastric nerve which gets injured. In hernia, it is ilioinguinal nerve which gets injured. And in laparoscopic hernia, it is the lateral cutaneous nerve of thigh which gets injured. So, these 3 nerves are important nerves which they do ask. So, this is the myopectineal orifice of Frouchot here. Very simple. What are 4 boundaries? Laterally, iliopsoas, the psoas muscle you can see. Superiorly, conjoint tendon. Medially, it is the rectus muscle. And inferiorly, it is the pubic bone having pectineal ligament. Tacker का मतलब, tacker is like a nail, like an anchor. So, जैसे दीवार पे कील ठोकते हो ना, it's just like a nail. So, we put a nail to fix the mesh. And we should not do any dissection and fixation in this area. Just now I explained why. In last 10 minutes, I'm only explaining this, why we don't put tacker or mesh here, because that's a dangerous area. One is having vessel, one is having nerve. So I hope you have understood. Yeah, Rutherford, I'll tell you. I'll answer your question. Anuchan, just give me 2 minutes. So I hope you have understood कि इस triangle में या इस area में कोई dissection क्यों नहीं करते, क्योंकि टैकर इज जस्ट वन वर्ड. इवन अगर मैं कहता हूं सूचर नहीं लगाएंगे, टैकर नहीं लगाएंगे, एंकर नहीं लगाएंगे, डिसेक्शन नहीं करेंगे, द कंसेप्ट इज सेम. दैट्स एरिया हैविंग टैकर इज जस्ट वन वर्ड टू फिक्स द मेश. लेकिन हम कुछ नहीं करेंगे एक्सेप्ट डिसेक्शन. आई विल नॉट डू एनी काइंड ऑफ फिक्सेशन एनीथिंग, क्योंकि दिस एरिया कंटेन्स वेसल एंड नर्व. Okay, so this is a dangerous area. Triangle of doom and triangle of pain. Lateral boundary of which lateral boundary is here, ye peritoneum, or ye iliopubic tract, or ye testicular artery. These are the three boundaries. Okay, so going back to myopectoral orifice of Rochard, four boundaries. What are the Rutherford Morrison अभी मैं बता रहा हूं. So, myopectoral orifice of Rochard की क्या इंपॉर्टेंस है? इसकी इंपॉर्टेंस है that this is the area we need to reinforce in hernia. The mesh should cover this area because the indirect hernia comes out from here, direct hernia comes out from here, and femoral hernia comes out from here. तो तीनों ही hernia यहीं से आते हैं. So, you have to reinforce this area called myopectoral orifice of Rochard, which you see from inside. I have drawn it from outside क्योंकि बाहर से समझना आसान होता है. So this is the psoas, this is the conjoint tendon, this is the rectus, and this is the iliopubic tract. Or sorry, this is the pubic bone. This one here, pectineal ligament. So inferiorly, this is the pectineal ligament called pecten pubis, shown by green color, written here. Laterally, it is psoas, written here, iliopsoas. Medially, it is rectus, rectus abdominis, and superiorly, it's conjoint tendon. So, this is the boundary of myopectoral orifice of Rochard. Okay? Now, one question was regarding Rutherford Morrison incision. Let me explain. You have at least 4-5 questions with one question that was asked last year at NICT and the answer given is wrong in your online lecture, in your book. I'll explain that. Dekho. That's not part of today's lecture, but this is the question. So let me explain. Dekho. For appendix, we make an incision here called gridiron incision. Or it's also called, though gridiron is the name, but some people call it McBurney incision. Some people call it MacArthur incision, but it's gridiron. Three muscle you come across: external, oblique, internal, and transverse abdominis. You don't cut, you only split. So gridiron is a muscle splitting incision, no risk of nerve injury. But if I extend this incision laterally, remember the extension is only lateral, which is a MCQ. So only lateral extension can be done and convert this into muscle cutting incision. And we call it Rutherford Morrison incision. One question asked last year was, which muscles are cut in Rutherford Morrison? And I saw almost all books are saying three muscles are cut: external, oblique, internal, and transverse abdominis, which is wrong. External oblique direction is like this. So it's same direction what my incision direction is. So I can simply split. But internal oblique goes like this, it needs to be cut, and transverse abdominis goes like this, it needs to be cut. So only two muscles are cut when gridiron is converted into Rutherford Morrison incision, which is a muscle cutting incision. Which two muscle? Transversus abdominis and internal oblique. External oblique is not cut. And which nerve may get injured here? Iliohypogastric nerve. So you have these questions. And Lanz, another incision for appendectomy, is a muscle splitting incision. There also the nerve will not be injured. So only one incision may injure the nerve, which is a muscle cutting incision, which is a Rutherford Morrison incision. Lanz and gridiron is muscle splitting, so nerve is not injured there. So this is just to answer the question which was asked, which incision, okay? So that finishes the hernia part, the triangles. Now before I move on to GIT topics, मैं एक छोटा सा point बता दूं. देखो, this is the area, look at the screen please. This is the area here where I will reinforce, like here, where I will reinforce, and in this area I will not find any major vessel. I can fix the mesh very clearly, safely here. I will only find the dangerous thing here and here, where I'll not go. But unfortunately, in 25% normal individual, 25% cases, this is the obturator artery and this is the inferior epigastric artery. You already know this is the triangle of doom and this is the triangle of pain, where I'm not going to venture, I'm not going to fix the mesh there. I'll only fix the mesh in this area, But as I said, in 25% normal individual, we can have a artery connecting the obturator with inferior epigastric, called accessory obturator artery or corona mortis. Corona means crown, mortis is death. So if one is not aware of this artery, he can have very torrential bleeding, and this will, he'll be in trouble if he doesn't know the anatomy and doesn't know that there can be artery here. So one should be cautious of this artery. Which artery? In lap hernia, corona mortis. And where it is? It is actually in a very safe area. Otherwise, we don't get an artery there. So this artery is connecting obturator. This O is obturator and inferior epigastric artery. So this is an aberrant artery called accessory obturator artery connecting obturator to inferior epigastric artery. Okay, corona mortis. This is the name of the artery. Now let's start quickly the GIT topics. Dekho. In esophagus, the first topic is Zenker diverticulum. As you know, in cervical esophagus, this is the gale wala esophagus, we have two muscle, oblique one called thyropharyngeus and horizontal one called cricopharyngeus. In between these two, there is a triangular area called Killian's dehiscence. Killian, Killian's dehiscence. And this is a weak area, and this is a sphincter. This muscle acts as a sphincter. Cricopharynx is a sphincter. So during deglutition, it should relax. First karo ki mareez khana kha raha hai, patient is eating, and the sphincter remains closed. It doesn't open. Pressure is high, and there's a weak area. So we will have a outpouching from here called Zenker diverticulum. Zenker is a protrusion through Killian's dehiscence. Why? Because it's a weak area and distally the sphincter is closed, the pressure is high and it pushes the wall. This is directed posteriorly. The defect is backward, posteriorly. And this is a pulsion type of diverticulum. Pulsion, pulsion. What is pulsion diverticulum? When you push from inside. What is traction diverticulum? When you pull from outside. So it's a push from inside, so it's a pulsion type of diverticulum. Of course, false diverticulum. It's acquired diverticulum, having only mucosa and some mucosa, muscle splits and the... So Zenker is a protrusion through Killian's dehiscence. What is Killian's dehiscence? A defect between thyro and cricopharyngeus in cervical esophagus directed backward. It's a pulsion acquired diverticulum, usually presents in old males after the age of 60. Dysphagia is the first symptom, but regurgitation, halitosis may also be there. The investigation of choice is barium swallow. So this is a red zone image for you. Like triage, where we do color coding, red, yellow, green, black. Here also I'll do color coding for examination for you. So in radiology, in GIT, what are the red zone? This is one of the red zone X-ray. I'll show you some more. So very, very important X-ray for you. So, no, Sandeepan, this is a very basic thing. It's a foundation bad teaching. If you ask this kind of question, it will take much more time. You see, diverticulum in GIT can be of two types, congenital or acquired. Congenital like Meckel's. Meckel's will have all the layers, and acquired will have only mucosa, some mucosa, lacks the muscle layer. So how to differentiate congenital, acquired? No muscle in acquired. Like Zenker is acquired, Meckel's is congenital. Now in acquired, we have two types, pulsion and traction. Pulsion and traction. Pulsion is push from inside. Pressure is high. And you have push from inside like Zenker. And traction is pull from outside. बाहर से खींच के निकाला. बाहर से खींचा और ये अंदर से धक्का मारा. So when you push from inside, it's pulsion. When you pull from outside, it's traction. Okay. So Zenker is a type of pulsion diverticulum. Okay. And X-ray is barium is very important. What's the treatment? Diverticulectomy and cricopharyngomyotomy. Diverticulectomy and cricopharyngomyotomy. But we have one more procedure, Dollmann's operation. Dollmann's operation is a endoscopic procedure only for 2 to 6 centimeter size diverticulum. So when the diverticulum is 2 to 6, we can do Dollmann. But any size we can do. diverticulectomy and cricopharyngomyotomy, which is usually the surgery of choice. But now Dolman uses linear stapler. We are using staplers, endoscopic staplers. So we can only do 2 to 6. But if I am using CO2 laser to cut, then I can do any size. Then size is not a consideration. So Dolman done by stapler, the conventional, the original Dolman has a size constraint, only 2 to 6 centimeter. But if CO2 laser is being used, then you can go even for smaller and bigger diverticulum. So this is about Zenker. This is a 2018 or 19 NEET question. Dolman operation is done for what? So Dolman, the name only they asked. Dolman is for Zenker diverticulum surgery. Okay. Now topic number 2. Tracheoesophageal fistula. Which is the most common type? The proximal end is closed and the distal end is connected. This is called type C. So type C is more than 85%. Most common is type C. Proximal closed, distal connected. So second point. What is the presentation? Patient will have continuous drooling. You can see here, he cannot swallow anything. This is closed, so he simply cannot swallow anything. So he will have continuous drooling of saliva, frothy saliva. And whenever he is fed, he get aspiration and choking. When you give, just give me 1 second, let me make it silent. So whenever the patient is fed, child is fed, because he cannot swallow, he will have drooling and he will have regurgitation, he will have aspiration. Only H type, the H type is type E, where it is like this, and you can see continuity is there. So here the patient presents late because he can swallow, but of course he'll have aspiration and choking. All other type, no, non-bilious vomiting, there's no vomiting here. The word is regurgitation. Who said non-bilious vomiting? Vomiting when the gastric content comes out. How the gastric content will come out? It's closed here. There's no vomiting. It's only regurgitation. Whatever you feed, that comes out. It's not the gastric content coming out. So there's no vomiting. Don't use the term vomiting. Use the term regurgitation. So patient will have continuous drooling of frothy saliva. Yes, aspiration will be there, of course, because it's close, so the milk will go into the lung. So aspiration, choking, and regurgitation. These are the main, and pneumonitis later on. These are the main features you get here. Okay. Then, so first 2 lines we have understood. Pass a tube and take a X-ray. The distance of tube is 10 centimeter and it gets stuck. So this is a very, very important X-ray for you. This I will keep in yellow zone. Yellow means red is most important, yellow less important, green least important, and black will not become a question. Black may become a question in theory, but not image-based. So this is an image-based question, but not as important, not in red zone, but yellow zone. Definitely a potential question. So any X-ray where you find the tube is getting coiled up here, tube is getting stuck here, and not going beyond this point, and there's a history of choking, aspiration, etc. So regurgitation will not be there in E type because he can swallow. Only aspiration and choking and pneumonitis will be there. So this is an important X-ray. Another point, if you do not find air in abdomen, then this is either type A or type B. Type A and B means both ends are closed, type A, and upper end connected is type B. So as you can see, this is closed and closed here. So this is closed and closed. So air cannot, the child cannot swallow air. So gasless abdomen. So if I find no air in abdomen, it means this is either type A and B. Other features will remain same. Tube gets stuck. And where the tube gets stuck? 10 centimeter from incisor. So tube will go here, and in adult, the tracheal, the carina is 25 centimeter, but in neonate it's only 10 centimeter. So it will get stuck at 10. Why I'm telling you 10 centimeter? इसलिए क्योंकि this is a love and belly line given in old edition, and around 20 years back they had a question in All India PG examination. The tube gets stuck here, true false statement. So it gets stuck at 10. Not a new line, not a new MCQ, unlikely to be asked, but it has already been asked. So the tube gets stuck where? 10 centimeter from incisor. And You should not push the tube. You'll perforate the esophagus. When it gets stuck, take a X-ray done, and you'll find the tube getting stuck here, and and drooling of saliva and aspiration is classical TEF. Okay. Then H type. For H type, most accurate is tracheobronchoscopy, which is a AIMS question. What is a shadow in A? What do you mean by A? I just said that no air in abdomen is type A and B. If you have not read TF, DVT is not a regular session of 4 days. I discussed GIT in 4 days. So I cannot finish GIT in 2 hours. DVT is not for someone who has not read the subject. I presume you have read. We are only here to revise. So type A is no air in abdomen. Normally you will find lots of air in abdomen. So no air in abdomen. So in X-ray you cannot differentiate A and B. Both will have the tube getting stuck here. Yeah, you can. In B, the tube may go into the lung. In A, it will not go into the lung. But X-ray alone is not sufficient, not a very good investigation to differentiate the types. It will only tell you that there is a TEF. So type H, we follow upper GI endoscopy and tracheobronchoscopy. So what we find in upper GI endoscopy and tracheobronchoscopy, we will find like this is a type H. If I pass a scope from here, I'll find a hole here. If I pass a scope from here, I'll find a hole here. So I can see the opening in trachea and esophagus endoscopy. This is more accurate. Which one? Tracheobronchoscopy. So in H type, both are done together. But if someone says which is the most accurate investigation to diagnose H type, don't say upper GI endoscopy, say tracheobronchoscopy. So tracheobronchoscopy here, this line is, this is an AIMS question, is most accurate. In theory and viva, if you ask me what you'll do for H type, I will say both. We do both together, tracheobronchoscopy and upper GI endoscopy. Out of these two, upper GI endoscopy is less accurate than tracheobronchoscopy. So that is the question. And if I have to do contrast study, barium being hyperosmolar and water insoluble, I can do barium solo, barium sulfate, but that will go into the lung because there's a fistula and will cause chemical pneumonitis. So we prefer iohexol. Why iohexol? Yeah, E and H are same, Aditya. E and H are same. The shape is like a H, see? This is the esophagus going straight, this is the trachea, and it's connected. So because shape is like a H, we call it H type. So both are same. So iohexol is safest contrast because it is water soluble and low osmolar. Gastrographin is also water soluble, slightly higher osmolar. So for abdomen, if there's a leak, we prefer gastrographin. In thorax, if there's a leak or it can go to trachea, lung, then we prefer iohexol. So in thorax, we prefer iohexol. In abdomen, we prefer gastrographin. But overall, barium is very, very good if there's no leak. So we don't go for water soluble contrast. We only order barium sulfate, barium solo, barium meal, barium enema. But in case there's a possibility of leak, I'm not saying barium is contraindicated. No, it's not. We do barium. It's more accurate. But it's not as safe as iohexol. So iohexol is safer. Yeah, mediastinitis तो खैर यहाँ नहीं होगा क्योंकि यहाँ पे mediastinum में लीक नहीं कर रहा है, but it will go into the lung and cause pneumonitis. हाँ, अगर perforation होता तो mediastinitis हो सकती है. So it's not mediastinitis problem here, it's chemical pneumonitis problem because the content will go into the lung, to the fistula. But in case it leaks and goes mediastinum, then it will cause mediastinitis. Okay? So, what is the treatment? A is image where you don't find any air in abdomen. No air in abdomen. If the tube is getting stuck here and no air in abdomen, then this is either type A and B. Both are rare. A is around 6-7%. B is only 2%. I told you type C is most common, more than 85%. So normally in TEF, you find the tube getting coiled up here and lots of air. If no air in abdomen, gaseous abdomen, then either A and B. So I guess now, you see, for a fit child, fit means what? How you define fitness? Weight more than 2.5 kg and no pneumonia. So, weight more than 2.5 kg and no pneumonia, do thoracotomy and repair. But in case child is sick, weak, aspiration pneumonitis, low birth weight child, weight less than 2 kg, do a feeding gastrostomy. And later on do the repair. He cannot sustain a trauma of thoracotomy. So whenever child is fit, do thoracotomy and repair, posterior lateral thoracotomy from the right side and repair. But how do you decide fitness? By weight and pneumonia. Weight more than 2.5 kg, no pneumonia, do thoracotomy repair. Weight less than 2.5 kg or 2 kg and pneumonia, do gastrostomy. Feeding gastrostomy temporarily, later on do the repair. Yeah. Waterston criteria is basically in pounds, not in kg. I told you in kg. And the Cameron operation, you can remember the name, Cameronheight, Cameron height operation. So for TEF, you can remember the name. There's no harm remembering the name. It may become a question, but unlikely. This was actually the first surgery, Cameron height, done in 1943 in TEF child. Successful surgery in TEF. That's why we remember the name. But the surgery has been modified drastically. So we don't do Cameron height as such how it was done 70 years ago. But you can remember the name Cameron height operation. Okay. So Cameron height is basically what you do in TEF. So this, and for pure atresia, we have a surgery by the name of Rajeev. Don't worry about the pages. I'll finish by 2 to 30. Don't worry about pages. Just remain focused. So we do an operation called Fokker operation. Okay. So I'll repeat. TEF, most common type is, the TEF is an important topic for MCQ. Type C. Type C means upper closed lower esophagus connected to trachea. Presents with drooling of saliva, aspiration on feeding, not able to swallow anything. A and B will have no air in abdomen, scaphoid abdomen. And type E can swallow, but he'll only have aspiration while feeding. The investigation is put a tube and take a X-ray, radio-opaque tube. You will find the tube getting stuck at 10 centimeter. Or if it's a H-type tube goes in the stomach, then you have to go for tracheobronchoscopy and upper GI endoscopy, in which tracheobronchoscopy is more important. If you want to do contrast study, want to show the dye entry into the lung through the fistula, go for iohexol, which is safer. Iohexol is inconclusive, then you can go for barium with a relative risk of chemical pneumonitis. The treatment is basically the thoracotomy and repair if the child is fit. Weight is more, child fit, do. If weight is less, child unfit, aspiration pneumonitis, or do gastrostomy. Okay. Now, this is the next topic, Plummer-Vinson syndrome. What is Plummer-Vinson syndrome, also called Peterson-Kelly syndrome? This is a esophageal web. Where do we find this? Cricopharynx. Post-cricoid. Common in female, perimenopausal age, 40s onward. Associated with iron deficiency anemia. So any patient having koilonychia, glossitis, microcytic hypochromic anemia in the slide picture with dysphagia, this is the only DD you will see. So I show you a picture of koilonychia, pale conjunctiva, dyspnea on exertion, microcytic hypochromic anemia, and I said the dysphagia here. This is the only diagnosis. Plummer-Vinson syndrome. Very, very important topic. The X-ray is not important. The X-ray I'll keep in green zone. I mean, this X-ray alone will not come in exam. With clinical picture it may come, but image alone will not come. And this is a post-cricoid web, asymmetrical web. And it has a low risk of cancer. Treatment is balloon dilatation. Dysphagia caused by Plummer-Vinson is called sideropenic dysphagia. So these are the points you have to remember. So, sideropenic. Sidro means iron, penia means less. You know, thrombocytopenia, osteopenia, leukopenia. क्या मतलब होता है? कम. तो sidro means iron. Iron कम हो जाने को कहते हैं sideropenia. So, iron deficiency anemia is called sideropenic anemia. Not sideroblastic, वो अलग होता है. Sideropenic. And dysphagia is called sideropenic dysphagia. So, this is Plummer-Vinson syndrome. Not very important, but a relatively important topic for MCQ. Another esophageal sideropenic dysphagia. शुभम, सिड्रोपेनिक तो एक मेडिकल टर्म है ना, आयरन डिफिशियंसी. सो देखो, नेक्स्ट थिंग इज नो, लिक्विड सॉलिड इज नॉट ए इश्यू हियर. Liquid solid is only issue in achalasia cardia. In achalasia, dysphagia starts with liquid, while in cancer and all others starts with solid. So liquid solid is not an issue here. Only in achalasia, you remember, dysphagia starts with liquid. Or neurogenic problem like myasthenia, etc. Then dysphagia starts with liquid. But normally it starts with solid. So here liquid solid is not an issue. Okay? So next topic is B ring or Schatzki ring. Schatzki ring is it's called B ring. This is a ring which is symmetrical. The previous one, Plummer-Vinson, was asymmetrical, and this is symmetrical. So Schatzki ring is symmetrical, found in lower esophagus. Where do you find it? Only found in sliding hiatus hernia. You see, this is an image of sliding hiatus hernia. And here we find a ring just above GE junction, which is symmetrical. So sliding hiatus hernia causes reflux, and reflux causes the ring. So Schatzki ring or a B ring, this is a sliding hiatus hernia, this is the stomach. So Schatzki ring or B ring is a symmetrical, again mucosal, no muscle here, both Plummer-Vinson and Schatzki ring, no muscle. It's not a full thickness ring or stricture, it's only mucosal ring and some mucosal ring. So this is a symmetrical ring, unlike Plummer-Vinson, which is asymmetrical, at GE junction, associated with sliding hiatus hernia, and presents with, this is important, very mild dysphagia, only solid dysphagia, no liquid dysphagia. So remember, no liquid dysphagia. Schatzki ring has no liquid dysphagia. If a patient is having mild intermittent dysphagia, no liquid dysphagia, it's Schatzki ring. And the food bolus can get stuck here, that is called Steakhouse syndrome. So this is the most common condition of Steakhouse syndrome. Steakhouse का मतलब ये बहुत पुरानी कंडीशन है, ये कई सालों से, मतलब 100-200 साल से भी नो. So in European countries, in the coastal area, for sailors, they used to have steak houses. जैसे इंडिया में chicken and kebab houses होते हैं. Steak is a roasted meat. So the sailor will come, he'll take a roasted meat, he'll take a beer mug, or he'll take some daru and he'll swallow. तो वो bolus of the food gets stuck here. उससे कहते हैं steak house syndrome. It's an emergency because the food bolus getting stuck in the esophagus. He cannot eat now. So 100 years back, pepsinogen, papain solution was given. कि pepsinogen पिला दो. Pepsinogen is actually proteolytic enzyme. It will make the meatball little softer and smaller, और फिर वो धीरे से आगे निकल जाएगा. Now we don't give pepsinogen, we do endoscope and remove. So it's a question, Steakhouse syndrome, what is the most common cause? Steak is roasted meat. It's not necessary that the meat gets stuck here. Even anything like orange pith can get stuck here. Usko chew nahi kara, swallow kar liya, it gets stuck here. So Schatzki ring is the most common cause of Steakhouse syndrome, followed by DES, diffuse esophageal spasm. So this is the Steakhouse syndrome. Sunil, you do not know anything. Don't talk slow and fast. Okay? So you do not know anything. So don't talk slow and fast. Just listen what I'm saying. Most of MCQ will come from this only. So barium swallow is basically the investigation. Even the barium swallow they have asked in PG. But in NEET, I doubt that they'll ask barium swallow. So in general, what Schatzki ring is, why it's called B ring? Just above this, we have a narrowing here called A ring, which is transient, disappears, and it's muscular ring. So A ring is muscular, and this is transient, disappears, doesn't need treatment. And this is the C ring, which is caused by diaphragm. So it's in between A and C ring, so it's called B ring, but only pathological ring is B ring, which can cause dysphagia. A and B ring will remain silent. A and C ring, we are not bothered about A and C ring. Now, this is a very, very important X-ray for you, red zone X-ray. No, Sunil, it's not personal. Huh? Don't feel bad. थोड़ा सा ऐसा होता है, don't worry. Huh? Don't feel bad. It's not personally for you. सबके साथ ऐसा होता है. So you see, this is a bird beak sign, and this is a very, very important sign for achalasia. If it is long, we do call it rat tail sign. But rat tail sign more often we get in cancer. So what points we need to know about achalasia? देखो, पहला point जो सबसे important है, that achalasia is not a stricture, not a narrowing, not a stenosis. The lumen is absolutely normal. So अगर मैं endoscopy pass करता हूँ, it will simply go through the LES. What's the problem in achalasia? Failure of relaxation. Remember, again I'm repeating, the lumen is not stenotic. The lumen is normal. The relaxation is not there. So when there's no peristalsis, no relaxation, you got dysphagia. So first point is, it is failure of relaxation. Second point, due to absence of Aurobac plexus. In GIT, we have two plexus, Aurobac and Meissner's. Aurobac is also called myenteric plexus. So mesenteric and orobac are same, and another plexus which is MEISSNERS, Meissner's plexus, is not affected here. So this is a very, very commonly asked question that in achalasia, what is false? One option will be Meissner's plexus are affected. No, Meissner's are not affected, only orobac. And in orobac, it's not 100% absence. Only the inhibitory ganglions are absent. So I'm repeating, like in Hirschsprung. In Hirschsprung, 100% ganglion absent, but here only inhibitory ganglions are absent. That too in mesenteric or orobac plexus, not in Meissner's plexus. That's the first point you have to remember. And it's failure of relaxation. नंबर 2, नहीं टॉक्सिक मेगाकोलन में नहीं भैया आशीष, क्या बातें करते हो तुम लोग. टॉक्सिक मेगाकोलन इज ए कंडीशन ऑफ अल्सरेटिव कोलाइटिस. टॉक्सिक मेगाकोलन थोड़ी, दैट्स कॉल्ड कंजेनिटल मेगाकोलन या Hirschsprung disease. Toxic is something different. So, but you are correct. In megacolon congenital, 100% absence of ganglion. Here only inhibitory fiber, that too orobac plexus. Number 2, all these MCQ one-liners. Secondary achalasia is caused by Chagas disease, which is common in South American country. Number 3, pseudoachalasia is due to cancer. Not cancer of esophagus, but cancer of surrounding area like lung, cardia, pancreas, most common cardia. So, secondary achalasia is due to cardia, cancer, pseudoachalasia due to Chagas, and the presentation is young age, 20 to 40 years. Achalasia is not a condition of children, not in old age. It's condition of young age. Let's say around 20s and 30s, maybe up to 40s, but not beyond 50, 55, 60. And this is a condition where dysphagia starts with liquid. तो ये जरूर याद रखना कि यहाँ पे liquid से शुरुआत होती है. Later on solid also, but to begin with liquid. And it increases the risk of squamous cell cancer. So this is the esophagus. This is the area which is having loss of ganglion, the lower esophagus. But this is the area, lower esophagus. But the cancer you get in this area, the dilated part, the normal part, which is having normal ganglion. So achalasia cancer is not seen in lower part. Had it been in lower part, it would have been adenocarcinoma. So lower part में वहां नहीं होता जहां पे ganglion नहीं है, वो होता है जो dilated है. So in achalasia you get the cancer in the dilated part, the upper and middle part, and that's squamous cell cancer, not in the egg ganglion part. Egg ganglion part is only the lower part. The barium should be, now again, manometry is gold standard, because very often I ask children, kya karaoge? They say manometry. No, manometry is gold standard, but not the first investigation. First investigation is endoscopy. All dysphagia endoscopy is first, followed by barium if endoscopy is kind of inconclusive. And barium will show rat tail sign or bird beak sign. Then only comes manometry if it is inconclusive. So manometry is gold standard, but not the first investigation. Manometry is the last investigation. Tone of LES could be normal. No, it's not Aladdin syndrome. आप लोगों ने उल्टा सीधा पढ़ रखा है. Let me explain. Tone is, so tone we know by manometry. What do we get in manometry? Two things. Number 1, non-relaxation of LES. And number 2, no peristalsis. These are the two features you get in LES area. Non-relaxation, and in the body of esophagus, no peristalsis. Peristaltic wave, I'm not saying no pressure. Pressure can be normal, pressure can be low, pressure can be high. So in achalasia, we do not rely on the peristaltic pressure. There's a Chicago classification. In type 1 pressure is normal, type 2 and 3 pressure is more. So don't worry about the pressure. Pressure can be normal, can be high, can be low. The diagnostic features are non-relaxation of LES and absence of peristalsis. This is what you have to know. And it's not called, okay, so we have a AAA syndrome, also called All-Grove syndrome as written by Deepika. AAA syndrome is alachrymia, chromosome 12, autosomal recessive, Aladdin gene, A for achalasia and A for adrenocortical insufficiency, which doesn't respond to ACTH. So alachrymia, achalasia and adrenocortical insufficiency is called AAA syndrome or All-Grove syndrome, but no, this is not an important syndrome. ये मैं skip कर देता अगर आपने लिखा नहीं होता तो it's not needed. The 20-25 syndromes of GIT important syndrome, it's not one of them. So I really doubt कि आपसे पूछा जाएगा. But just to revise, there is a familial type of achalasia called All-Grove syndrome or triple A syndrome. The 3 A's stands for alachrymia, achalasia cardia, and adrenocortical insufficiency, which doesn't respond to ACTH. It's not pituitary hypothalamus problem, it's a primary adrenal cortex problem because it's not responding to ACTH. This is called triple A syndrome. All grove nahi. All grove. ALGROVE. All grove syndrome. All grove. Okay. So, and this part is not important. If you know, it's good. If you do not know, don't worry about it. ये नहीं सोचा कि उसको पता है, मुझे नहीं पता. ये नहीं पूछा जाएगा. Don't worry about it. So, and I'll repeat. All patients are first investigated by endoscopy. Always when I say dysphagia, what will do? Say endoscopy. लेकिन ध्यान रखना, if endoscopy can perforate the esophagus, कब perforate कर सकता है? Very severe dysphagia. Patient cannot even swallow liquid. वो कहता है साहब मैं खाना ही नहीं खा सकता, पानी भी नहीं पी सकता, और there's a neck dysphagia, गले में अटक रहा है. Then we order barium before endoscopy. So barium can be ordered before endoscopy when endoscopy might perforate the esophagus. Like very severe dysphagia, complete dysphagia, neck dysphagia, then we should order barium before endoscopy as a safety, as a precaution. But otherwise we can directly go for endoscopy. And treatment is Heller's myotomy. This name you have to remember. Heller's myotomy is one of the important surgery. The 2025 surgery name in GIT, you have to remember, it's one of them. Heller's myotomy. And Heller's myotomy is just cutting the muscle of the sphincter. Normally leads to reflux, so door fundoplication can be done along with it. Fundoplication is not for achalasia. Fundoplication is only for reflux. So, which is caused by the surgery. So, Heller's myotomy will cause reflux. For that, we can do door fundoplication. Just as a protective mechanism to prevent reflux after surgery. Heller's myotomy is the treatment done by abdomen, not by thoracotomy, by laparoscopy or laparotomy. पेट से करते हैं, thorax से नहीं करते. POEM is another surgery, per-oral endoscopic myotomy. Per-oral endoscopic myotomy. That's another surgery done for achalasia. Now, this is just a X-ray. I want to remember, this topic is not asked, but this X-ray is very frequently asked. It's a red zone X-ray for you. जहां पे वो पूछते हैं कि क्या है. So this is called corkscrew appearance seen in diffuse esophageal spasm. So corkscrew appearance in diffuse esophageal spasm, very very important X-ray. ये जरूर याद रखना, ये पूछा जाता है, frequently पूछा जाता है. Now sliding and rolling hiatus hernia, you can see this is the normal GE junction. In sliding, the GE junction and cardia goes up. This junction here has gone up, while in rolling, the junction is there where it should be below the diaphragm, but the fundus goes up. So, this is sliding and rolling. Sliding is 95% or more than 90%, rolling is around 5%. Rolling is also called paraesophageal. So, the pouch goes up is rolling, the G junction goes up in sliding. Sliding presents with reflux. The main presentation is reflux and managed conservatively. Rolling presents with complication, dysphagia, pain, and ulcers. So rolling is always operated. Why? Very high risk of complication. So rolling surgery is always indicated irrespective of size, while in sliding only reflux will be present and generally managed conservatively. The treatment is same what we do for GRD, fundoplication and Allison repair, cruroplasty. One more word. In rolling hiatus hernia, there could be ulcer here in the fundus called Cameron ulcer. Cameron ulcer. Cameron ulcer. So, ulcer has name in stomach, like in burn we call it curling ulcer, in head injury we call it Cushing ulcer. So in rolling, like this is a rolling hiatus hernia, I've drawn it here. So one may find an ulcer in this. What nonsense. So one may find ulcer in this area, here, in the herniated part. This is called Cameron ulcer. C-A-M-E-R-O-N, Cameron ulcer, okay? Yeah, so one question is nutcracker. Nutcracker has no radiological finding. Nutcracker is only diagnosed on manometry. Only on manometry. And nutcracker presents with pain. Nutcracker, not dysphagia. First symptom is pain. Unlike atlasia, where first symptom is dysphagia. So normally, if you see in manometry, you will find peristaltic wave going like this. These are the normal peristaltic wave. Each one having a duration of say about less than 2 seconds and the height of about 60 millimeter mercury. But in nutcracker, you will find the wave is very high. This part goes in spasm, the lower esophagus. And the pressure is more than 180 and the duration is more than 6 seconds. So, more than 6 seconds. But this is not important. So, nutcracker is only and only diagnosed by manometry. It's not diagnosed by barium. Nutcracker has only one diagnostic test, manometry. Barium is normal. Duration is more than 6 seconds, not 7 seconds. 6 seconds, that's called O'Connell criteria. But I don't think in MBBS they'll ask this. So, this is sliding and rolling hiatus hernia. See here. This X-ray, I will say, will come in green zone, not red zone, not very important, but still important. Sliding may be red zone, but rolling is green zone. So this is a sliding hiatus hernia. This is a rolling hiatus hernia. Another feature in X-ray, rolling aka paraesophageal. Para means by the side of esophagus. So paraesophageal is rolling. See, ये जो abdomen का diagram है, when you take a normal X-ray, you find a air shadow here. That's normal. And this air shadow is in the fundus of the stomach. That's normal. We call it fundal gas shadow. But in rolling hiatus hernia, the stomach has gone here. So now the fundal gas shadow will be here. So you find retrocardiac air fluid level, something like this. The air shadow you are looking at here should have been here. So this X-ray will not come in exam. You can see the stomach also gone up. But theoretically in 2015 or 16 we had this question that there's a retrocardiac air fluid level. What is the most probable diagnosis? So this is So here, like this, huh? ये stomach ऐसे ऊपर चला गया, यहाँ पे air fluid level दिख रहा है. This is a hiatus hernia. So sliding and rolling hiatus hernia in X-ray may show retrocardiac air fluid level. ये line आप याद रखेंगे. Hiatus hernia, sliding and Schatzky ring, you cannot differentiate on barium at your level. So whenever you have any picture like this is a very genuine question, that how to differentiate. No, if you have a question like this, you will simply say sliding hiatus hernia. As I told you, Schatzky ring का X-ray नहीं आएगा, खाली theoretical question आएगा. Whether there is a ring here or not, only radiologist can tell you or endoscopy can tell you. In MBBS level or even for surgeons, we are not supposed to, we cannot make a diagnosis of ring is there or not. Radiologist can tell you. तो आप सिर्फ ये याद रखना कि स्लाइडिंग हाइटस की फोटो ऐसी आएगी. अगर ऐसी फोटो है, फॉरगेट अबाउट Schatzky ring, डोंट वरी अबाउट इट. Schatzky ring theoretical question होगा. ओके For all anatomical problems, stricture, diverticulum, hiatus hernia, investigation of choice is barium, not endoscopy. Barium swallow. So Zenker diverticulum, barium. Stricture, barium. Hiatus hernia, barium, not endoscopy. Okay? Yeah, air fluid level you get in both. Okay, so I guess this is clear. I'm not missing any question, or did I miss any question? Okay. So next topic is again a not important X-ray. This X-ray alone, I don't think that you will get an exam. So for X-ray, I'll give a black zone. Black means X-ray will not come. But theoretically, I'll keep this in green zone. Theoretically, they may ask this question. This is called double barrel esophagus. What is this? मान लो ये esophagus wall है और आपने endoscopy करा. You perforate the esophagus, it's perforation. But what if I only split the esophagus? उसकी wall को split कर दिया. Like in aorta, you call it aortic dissection. Here we call it esophageal dissection. So esophageal dissection is a term used while doing endoscopy when the endoscopy goes into the wall and splits the wall. Not through and through perforation. Otherwise it will call perforation. Splitting of the wall. So in dissection, you will find a sign called double barrel sign. Only remember theoretically कि साहब double barrel sign कहाँ मिलता है? Esophageal dissection. How do you manage? Conservatively. That's it. So this X-ray I doubt कि एग्जाम हो सकता है आ जाए भाई कुछ भी पूछ सकते हैं, but X-ray will not come. So this is the pouch and this is the esophagus called double barrel esophagus. ठीक है? And this you get in esophageal dissection. Manage conservatively. Now this is a feline esophagus. Again, the X-ray I'll keep in green zone, but theoretically it has been asked once, may be asked again. In esophagus, you find multiple transverse serration called feline esophagus. See here, I'll zoom it in for you. Can you see some lines going transversely along the wall of esophagus? This is seen in GERD and eosinophilic esophagitis. Yeah, it is iatrogenic, Mayank, while doing endoscopy. So, dissection is iatrogenic problem. So, eosinophilic and GRD, they give feline esophagus sign, which is MCQ. ये already आ चुका है पहले. ये आ चुका है. तो सिर्फ नाम पूछा गया है. Image, they have not asked. And I don't think इससे पूछा भी जाएगा. So, eosinophilic esophagitis and GRD both give feline esophagus. Foreign body, very important. Foreign body, no, in CMV you don't really get feline. In CMV you get serpiginous ulcer. In herpes simplex, the ulcers are punched out. In candida, curd-like, white patches. And CMV, serpiginous. These are three words you have to remember. They become MCQ. CMV will not come in exam as a barium. Barium is not diagnostic for CMV, endoscopy is. Yeah, Sakshi, you're right, serpiginous. So you see, foreign body in esophagus in AP view will appear like this. While in trachea in AP view will appear sideways like this. So end on appearance is esophagus, sideways appearance is trachea. How to differentiate coin from button batteries? Volcano-like again is herpes simplex. But herpes simplex, volcano-like is not a regular feature. You may get volcano-like. Herpes simplex, the ulcer could be like this. So it becomes a volcano-like. The edges are elevated or it can be flat. So volcano-like is not a classical feature. You may get it. Classical feature of herpes is punched out. This is the classical feature, punched out also. So I'll repeat. Candida, white patches like curd. Herpes, punched out. Painful, vesicle, volcano-like. All these are found in herpes, but punched out. And serpiginous, cytomegalo. These three words you remember, okay? So, कैसे differentiate करेंगे? Look very carefully. Probably you can see two rings here and only one here. So two ring you get in button batteries, double rim, while in coin you don't get this. And how to manage esophageal foreign body? This is important. This you get question. Last year भी पूछा गया है in शायद UPSC में. See, how to manage button, how to manage foreign body esophagus? If we have symptomatic patient like salivation, pain, dysphagia, symptomatic. Number two, button batteries. Number three, sharp foreign body. Needle, pin. Number four, magnets. And number five, size more than 5 centimeter. So any foreign body which is size more than 5 centimeter, button batteries, symptomatic, sharp and magnet is treated by endoscopy and removal, immediate removal. So ये indication है endoscopic removal के. Then if it is asymptomatic and it is smooth like coin, nut, bolt, anything, then what is the approach? And this is only for esophagus, not for rest of GIT. Keep under observation for 24 hours and repeat X-ray. So foreign body in esophagus should be managed by conservative if it is asymptomatic and smooth, only for 24 hours. Get a repeat X-ray. Now there are only two possibilities. Either the foreign body will be stuck in esophagus or it's gone down into the ileum, jejunum, etc. तो अगर फॉरेन बॉडी आगे चली गई है, देन यू लीव. और अगर foreign body after 24 hours still stuck here, it's impacted here, lodged here, then do endoscopy removal. So smooth and asymptomatic, we decide endoscopy after 24 hours. We give 24 hours for foreign body to go down. The narrowest part of GIT is cricopharynx. Narrowest organ is appendix, fine, but वो अलग है, वो continuity में नहीं है. Narrowest part is cricopharynx, 1.3 centimeter. So any foreign body which has crossed the narrowest part, most likely will cross rest of GIT. So if it is asymptomatic, no, magnet we should remove. Magnet, they get stuck together and they cause necrosis of the wall. So magnet should be removed. ठीक है? Understood this? तो ये foreign body में सवाल आता है. अब आता है next, congenital hypertrophic pyloric stenosis. Very favorite topic. This I'll keep in double red zone. Very, very important topic for you. CHPS is basically a congenital problem, although presents late, where the pylorus is hypertrophied. तो मान लो ये हमने स्टमक बनाया और ये हमने पाइलोरस बनाया, लेकिन इन CHPS द पाइलोरस गेट्स hypertrophied. तो in barium the pyloric canal is stretched, that gives a string sign, and the barium connected here in duodenal valve gives a mushroom sign. So it's a hypertrophy of pylorus causing gastric outlet obstruction, which is called CHPS. Common in males. To diagnose, how do you diagnose dissection? By barium swallow only. So common in males, 4:1 ratio. First born male child is little controversial. हमारी एक सर्जरी की बुक है Schwartz, बड़ी स्टैंडर्ड बुक है PG लेवल की. Schwartz has written that first born male child is a statistical error, creating controversy. But most books are still saying that first born male is correct, so we consider this correct. So common in male, first born male child presents with non-bilious projectile. Both words are important. Projectile, non-bilious, usually 3 to 6 weeks after birth. So 3 to 6 weeks के बाद, antenatal no problem, postnatal no problem. The child will have projectile vomiting. Due to projectile vomiting, stomach is always empty and child is always hungry. These are part of MCQ. Empty stomach, no food residue in the stomach, and hungry child. So empty stomach, hungry child, having non-bilious projectile vomiting, and on examination, you may find a olive-shaped lump in, olive means something like this, in epigastrium, and becomes more prominent during or after meal. Empty stomach, don't palpate. Ask the mother to feed the child when she is feeding, or immediately after feeding you palpate, you find the lump. So it's best palpated after meals, then child will have vomiting, stomach is always empty, and one can get left to right peristalsis. So left to right peristalsis, no polyhydramnios. Why no polyhydramnios? क्योंकि जो भी प्रॉब्लम है वो पैदा होने के बाद होती है. एवरीथिंग इज आफ्टर 10-12 days after birth. So no problem, antenatal ultrasound normal. Erythromycin not only maternal, even to child. So if I give erythromycin to mother or to child within 10 days after birth, there is a higher risk of CHPS. So erythromycin to mother and child both increases the risk. Investigation of choice is ultrasound. No, cricopharynx is the narrowest part of GIT, Sayyid, and followed by ileocecal junction. That is the second narrowest part. लेकिन अगर हम कहते हैं कि which is the narrowest organ, then you will say appendix. But in continuity, the narrowest part is cricopharynx, followed by ileocecal junction. Second narrowest part. Ileocecal valve is called valve of Bohin, B-A-U-H-I-N, valve of Bohin, and that makes the second narrowest part. So, a ultrasound is in PEM, protein energy malnutrition. So you don't find kwashiorkor or marasmus feature here because the history is not that long. Only dehydration and acid-base imbalance you get here. No marasmus or kwashiorkor. It's called congenital because there are certain antenatal factors that can cause this. So American book and pediatric book, they don't call it congenital. They call it infantile hypertrophic stenosis. But there are certain antenatal factors that can cause this, suggesting that the cause is probably congenital. The cause is antenatal, although presents late. So, target sign, antral nipple sign, cervix signs are signs on ultrasound. And you can see empty stomach, you can measure the length, you can measure the thickness, you can measure the width. Length more than 16 millimeter thickness more than 4 millimeter. These two figure you remember. Width you can forget. Length and thickness 16 and 4, and it's almost very important point. So in barium meal you have string sign, mushroom sign. See here, this is called string sign, this is called mushroom sign. और ये आपके इसी साल का INICT का, सी हियर स्ट्रिंग एंड मशरूम साइन, ये आपका इसी साल का INICT का सवाल है. मैच द फॉलोइंग. द ऑप्शंस वर स्ट्रिंग साइन, रैट टेल sign, football sign, and inverted umbrella sign. String sign, CHPS was the option. Rat tail sign, achalasia was the option. Inverted umbrella is seen in GI tuberculosis called Frischner sign, and football is pneumoperitoneum. So this is this year question only. So string sign, only remember the names. Photo nahi aayegi. So string sign, mushroom sign, double track sign, caterpillar, shoulder, and diamond sign. These are X-ray sign, barium sign. And plain X-ray will show single bubble sign, okay? Electrolyte abnormality, ये जरूर याद रखना. Hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. This aciduria is due to aldosterone. Apple core, how you get confused with apple core? Apple core I'll show you. Apple core का X-ray आगे है, दिखाऊंगा मैं आपको. Apple core is football sign you get in pneumoperitoneum, in perforation, in children. The whole abdomen is black. Apple core I'll show you. That's in tubular structure cancer, esophagus colon cancer. So this aciduria is due to aldosterone, and sodium also gets corrected due to aldosterone, which is why you don't get hyponatremia. So hypochloremic, hypokalemic, alkalosis and aciduria. This is a very important question. They ask कि भाई patient को vomiting हो रही है, gastric content निकल रहा है, क्या electrolyte imbalance होगा? Hypochloremic, hypokalemic, metabolic alkalosis plus aciduria. And another point, this is a non-surgical emergency. What I mean by this? Diamond sign is sign in barium. I mean that this is an emergency, but we don't operate unless we have corrected the electrolyte imbalance. So only when we correct the electrolyte imbalance, then we treat. And how do we treat? By surgery. But कभी surgery नहीं करेंगे, पहले fluid electrolyte imbalance सही करेंगे. Aldosterone, I said that this is the reason for paradoxical aciduria. देखो, कहाँ गया नाम उस बच्चे का? अनु. प्रॉब्लम क्या है ना कि आई कैन नॉट एक्सप्लेन एवरीथिंग. आई प्रिज्यूम कि आप बहुत सारी चीजें जानते होंगे. इन द स्टमक देयर इज HCl. तो जब वॉमिटिंग होती है और HCl का लॉस होता है, देयर इज हाइपोक्लोरेमिक अल्केलोसिस. दिस इज वेरी सिंपल कि भाई अल्केलोसिस होगी बिकॉज स्टमक से एसिड निकल रहा है. ड्यू टू अल्केलोसिस द यूरिन शुड बी अल्केलाइन. Lekin here the urine is acidic, which is why we use the term paradoxical. So I told you that there is exactly opposite what physiologically we should get. We should get alkaline urine because blood is alkaline. There is alkalosis. So why aciduria? Aciduria is due to aldosterone. ये मैंने लिखा. तो अगर आपको ये नहीं समझ में आया, इसका मतलब I cannot discuss in detail. This you बहुत सारी fill in the gap आपको अपने आप समझना पड़ेगा अपनी residual knowledge से. So paradoxical aciduria is due to aldosterone. This is what I said. Now what is the fluid of choice? The fluid of choice is N/2 saline KCl index. So this is a question. ये आपसे पूछा जाता है कि what is the best fluid to correct CHPS dehydration? N/2 saline. Normal saline is 0.9%. 0.9% का हाफ कर दो 0.45%. So 0.45% normal saline with dextrose and KCl. This is the fluid of choice. If not available, you can give ringer lactate. But ringer lactate will increase alkalosis. Just listen what I'm saying. देखो क्या है कि in trauma, in burn, in shock, क्या होता है? मेटाबॉलिक एसिडोसिस है ना. बर्न है, एनरोबिक रेस्पिरेशन होगा, एसिडोसिस होगी. ट्रॉमा है, एसिडोसिस होगी. दिस लैक्टेट goes to liver and gets converted to bicarbonate. So, bicarbonate, okay? So, this bicarbonate will counter the acidosis in trauma. But यहाँ पे तो बच्चे को already alkalosis है ना? So, यहाँ पे if I give ringer lactate, this will increase the alkalosis, which is why ringer lactate is not contraindicated, but not preferred. So, ringer lactate we avoid because we can give, but N/2 saline with potassium and dextrose is important. Another thing that you have to know, that KCl is only given when urine output starts. If there's no urine output, don't add potassium. Just give N/2 saline and dextrose. When the child has passed urine, then only add KCl. So potassium is added when potassium urine output starts. Surgery is Ramstead pyloromyotomy. Means you only cut the muscle and open the pylorus, not pyloroplasty. This pyloromyotomy term should not be confused with pyloroplasty. Pyloroplasty हम कब करते हैं? वो हम करते हैं outlet obstruction या drainage के लिए. Here we only do mytomy. We don't cut the lumen, don't open the mucosa. So I can give oral feed in 6 hours and I can discharge the child in 24 hours. So it's only pyloromyotomy. Ramstead. This is again an important name. Like Hiller's myotomy is important, ये भी बहुत important है. ये नाम जरूर याद रखना. Ramstead pyloromyotomy for CHPS. कब करेंगे? Electrolyte imbalance और dehydration करें. Dehydration correct हुआ कैसे पता लगेगा? Urine output more than 1 ml per kg per hour. So child having urine output more than 1 ml per kg per hour means dehydration has been corrected. You operate. Only cut the muscle and that's it. No, don't open the mucosa. Opening the mucosa is under surgery pyloroplasty. So उससे confuse नहीं करना है. खाली pyloromyotomy word use करना है. ठीक? Now, this is a very, very important X-ray. ये मैं बोलूंगा साहब, ये X-ray आपके लिए बहुत ही important है, बहुत पूछा जाता है. Gas under diaphragm. What it suggests? Hollow viscous perforation. So, all these are air below diaphragm. So, invariably you get a question that patient is on an NSAID, means adjacent ulcer, or patient has blunt injury abdomen and he is having pain, not able to pass flatus facies, guarding tendons, rebound tendons, and this is the X-ray. And then they ask, क्या करोगे और क्या है? So this is an air below diaphragm. Next step should be, pneumoperitoneum, perforation, hollow viscous. Next step should be first resuscitation, then laparotomy. Don't say laparotomy. Always say resuscitation followed by laparotomy. So this should be resuscitation, then laparotomy. देखो मैं आपको एक छोटा सा पॉइंट बताने जा रहा हूं जो मुझे लगता है बहुत बच्चों को कंफ्यूजन रहता है. If I say कि there is a ileal perforation, what you will do? Ileal, enteric typhoid perforation. बहुत सारे बच्चे कहते हैं omental patch repair. नहीं, omental patch is only and only for duodenal perforation or maybe rarely stomach, not for any pathology below the transverse colon. So ileal perforation is simply closed primarily. सीधा सीधा टाँक लगा के बंद करो, उसको कहते हैं primary closure, transverse primary closure. So don't say omental patch for ileum. Ileum is just primary closure. Only for duodenum and stomach we can do omental patch repair. Okay, so this is air below diaphragm. Another X-ray finding of pneumoperitoneum is we can see the bowel wall. What do we call this? Wriggler sign. This is a double red zone sign for you, air below diaphragm, and this is a green sign for you. Means it may become a question. हालांकि कम chance है, but हो सकता है regular sign. Other pneumoperitoneum sign you will not get X-ray. Only theoretically they ask, like football sign. Theoretically they can ask, but this X-ray might come in exam. You can see the wall of the bowel called Wriggler sign. Wriggler sign is another sign of your white line जो है ये bowel की wall है. इसको कहते हैं Wriggler sign. ये भी एग्जाम में आ सकता है. Air below diaphragm तो बहुत इंपॉर्टेंट, ये कम इंपॉर्टेंट, but again a potential MCQ. Wriggler sign. Wriggler triad is something different that you get in gallstone ileus. That Dr. Gaurav will discuss. वो liver में पढ़ाएंगे. Gallstone ileus का मतलब stone in the ileum, dilated bowel loop, and pneumobilia, air in the gallbladder. So Wriggler triad. So, regular triad is a triad of gallstone ileus, where you have stone in ileum, dilated bowel loop, and air in the gallbladder and biliary tree. Regular sign is a sign of pneumoperitoneum. The next sign, which is very important, is double bubble sign. ये भी आपके नहीं, Anushka, you will never have pneumoperitoneum in a asymptomatic patient. Pneumoperitoneum can be iatrogenic, like you have done laparoscopic surgery and you have insufflated CO2, or it is perforation. Sometimes what nature does, it seals the perforation by omentum. Patient आपके पास आया, he is having or she is having guarding tenderness and X-ray showing air below diaphragm or CT showing air. But the bowel sounds are present, she is passing flatter species, don't operate. This is most likely sealed perforation. For that we order CT scan to confirm. But generally whenever you have peritonitis and air below diaphragm, unless the patient is very lucky, the nature has sealed the perforation with the help of momentum, we don't operate. Otherwise we have to go for laparotomy. Regular sign bandhana is, मान लो आप एक्सरे करते हो ना, तो आपको भाई देखो ना, आप में से बहुत सारे लोग टाइप ए पर्सनालिटी के हो. टाइप ए पर्सनालिटी का मतलब ना, डॉक्टर सचिन आपको पढ़ाते होंगे कि हमने किसी को बोला हमें 4 बजे मिलना है, हम 3 बजे से टेंशन में आते हैं उसे 4 बजे मिलना है, तो ये पर्सनालिटी ठीक नहीं है. स्ट्रेस करते हैं, एंजाइटी करते हैं. रिलैक्स होकर पढ़ो. हाँ, ये नहीं कि 45 पेज बचे, 100 पेज बचे. अरे बिलीव मी, मेरी फ्लाइट है 8 बजे भाई बॉम्बे की, तो मुझे तो खत्म करना ही है ना. तुम्हारी फ्लाइट थोड़ी है, मेरी फ्लाइट है 8 बजे. टुमारो आई हैव टू टेक लेक्चर इन बॉम्बे. तो डोंट वरी, है ना. ये नहीं कि अब 100 पढ़ने बचे हैं, 10 मिनट बचे. अरे यार पढ़ो शांति से, चिंता मत करो इसकी. आई हैव ए फ्लाइट, आई एम टेलिंग यू, मेरी फ्लाइट है, मैं शाम की पार्टी नहीं अटेंड कर रहा डैम्स की. तुम्हें तो कुछ नहीं करना, बैठ के पढ़ना है. सो डोंट वरी, डोंट बिकम टाइप ए पर्सनालिटी. रिलैक्स होकर जीना सीखो. सो यू सी व्हाट आई वाज सेइंग, मैं भूल ही गया मैं क्या कह रहा था. हाँ, मैं बता रहा था कि मान लो ये बावल है और इसके अंदर आपने एक्सरे करा, तो यू विल ओनली फाइंड एयर इनसाइड द बावल. बट व्हेन देयर इज ए परफोरेशन, द एयर इज आउटसाइड द बावल. अब क्या होता है कि एयर इज ऑन बोथ द साइड, सो आई कैन सी द बावल वॉल इन बिटवीन. So this white wall is only visible when air is on both the side, and white wall when you can see in the X-ray, this suggests pneumoperitoneum. This is called regular sign. ठीक है? So, हाँ, शाम को डांस पार्टी है विलियम, but my schedule is so tight कि I never attend any party. Almost 7 days I work, or sometime I spend time with my family, so I don't attend parties, I don't see movies, and I'm very comfortable with that life. So you see. Yeah, so I was saying कि देखो, duodenal atresia में there is a obstruction in second part of duodenum. So you find one air here, one air here. This is called double bubble sign. This is a sign of second part duodenum obstruction. अगर मान लो stomach का obstruction है, gastric outlet obstruction, then we only have one air. तो अगर हमने एक्सरे में we have a air here, this is single bubble sign, gastric outlet obstruction. और अगर हमारे पास एक एयर शैडो यहां पे है और एक यहां पे है, then this is a double bubble sign. Where the obstruction is, it's in the second part duodenum, and then jejunal obstruction will have triple bubble sign. Okay? So, double bubble sign is a sign of second part duodenal obstruction found in congenital duodenal atresia or Latz band or annular pancreas. So let's focus on the study. This is a erect view, this one, and this is a supine view. In supine you just find two air shadow, and erect you find the air fluid level. Both are double bubble sign. So what are the features we need to know about duodenal atresia? This is second part duodenal congenital obstruction, more common with Down syndrome, presents with polyhydramnios. 50%. Why polyhydramnios? Prior to delivery, there is obstruction. And double bubble sign, treatment, and bilious vomiting immediately. Unlike CHPS, जहां पे vomiting non-bilious है और 4-5 हफ्ते के बाद होती है. Here the bilious vomiting is immediately after birth. So within 24 hours, whenever you give feed, he'll vomit. And bilious, because obstruction is distal to ampulovator. And treatment is duodenoscopy. Diamond shaped, called Kimura operation. The name is not important. Latz band you get in malnutrition. So diamond shape, duodenoscopy, Kimura operation. The name is not important. It's not one of the surgery which you need to remember. अगर याद है तो अच्छी बात है, but Kimura operation आपसे नहीं पूछा. It's not like Ramstead palmarotomy or Heller's myectomy or Dolman operation, those are the important name, Whipple's operation, Kasai operation, ये सवाल नाम नहीं आएगा. But remember, Kimura is duodenoscopy. Now, this is the mid-gut volvulus. Let me first explain you. देखो क्या होता है. I'll come interior so that you see me. देखो क्या होता है कि in a fetus, the GIT is outside the abdomen in the yolk sac. When it goes back in abdomen, cecum comes here in the left side. That is 6 to 9 weeks. Then cecum comes here and then here. So this rotation normal takes place from 6 to 9 weeks. Cecum goes in and then comes here by 12 weeks. So this is anti-clockwise 270 degree. So normal rotation is anti-clockwise 270 degree from 6 to 12 weeks. If the cecum stops here, non-rotation. Cecum stops here, incomplete rotation. Cecum comes here in the right fossa and then doesn't get fixed, non-fixation. That will cause cecal volvulus. So there are three presentation of malrotation. Either incomplete when the cecum is in the left hypochondrium, non-rotation cecum in the left hypochondrium, incomplete cecum in the right hypochondrium, and non-fixation causing cecal volvulus. So this is a normal rotation. Now this, if the cecum stops here on the left side, non-rotation. Cecum stops here, incomplete. And cecum goes behind the duodenum, that is reverse rotation. ये reverse rotation होता है. So, mid-gut volvulus क्या होता है? पहले आप ध्यान रखोगे, what is the normal rotation? 270 degree anti-clockwise. Okay? Non-rotation cecum यहां कैसे प्रेजेंट करेगा? ये प्रेजेंट करता है लैट्स बैंड ऑब्स्ट्रक्शन. I'll draw. ये स्टमक है, ये duodenum है, और cecum is here. This is the cecum shown by blue color because it's not rotated. And here there's a band going like this, compressing the second part duodenum. This is called Latz band. So non-rotation presents with Latz band obstruction, incomplete presents with mid-gut volvulus, and complete rotation non-fixation presents with cecal volvulus. तो अगर ये cecum यहीं पे रुक गया तो Latz band करेगा, यहां आके रुक गया तो mid-gut volvulus होगा, और यहां पे आके अगर फिक्स नहीं हुआ तो सीकल वॉल्वस बाद में होता है, अडल्ट्स में होता है, मतलब बच्चों में, बट लेटर ऑन, नॉट इन न्यूनेटल एज. सो लैट्स बैंड ऑब्स्ट्रक्शन प्रेजेंट्स right at birth or within few hours of birth or within few days of birth, obstruction second part duodenum, Latz band obstruction. Here, volvulus, mid-gut volvulus is a late phenomena after few days or few weeks of birth. So in barium you find the corkscrew appearance, not as important as the corkscrew appearance of DES, but यहाँ भी corkscrew appearance मिलता है barium में, और CT scan में whirlpool sign. These are the signs of malrotation के बाद volvulus होने का, mid-gut volvulus. So mid-gut volvulus signs are corkscrew appearance in barium and whirlpool sign in CT scan. Treatment of malrotation is Latz operation, जो आगे हमारा कुछ topic है surgery पे. So I'll tell you this later on. Okay. So I'll repeat. Normal rotation is 270 degree anti-clockwise. The bowel comes in the abdomen from 6 to 9 weeks and 9 to 12 weeks comes in the right iliac fossa and get fixed. 12 हफ्ते तक पूरा हो जाता है. If the cecum stops here, that is non-rotation, presents with Latz band obstruction, duodenal obstruction, bilious vomiting right at birth. Incomplete rotation, cecum in subhepatic will cause mid-gut volvulus, and complete rotation but incomplete fixation will cause cecal volvulus later on. And so this, there are many questions on this. एक सवाल तो ये है कि normally क्या होता है? This is the duodenum. This is the superior mesenteric artery which is anterior to duodenum, and the anterior most is colon. Colon सबसे आगे है, then artery, then duodenum, retroperitoneum. So posterior duodenum, then artery, then colon. If the relation is reversed, see here. The colon has gone posteriorly, then there will be artery, and anterior most is duodenum. Anterior rather than being posterior most has become anterior most. This is called reverse rotation. तो ये भी सवाल एक बार आ चुका है कि the duodenum is anterior to colon. What is this? This is a reverse rotation. So you have 5-6, not very important topic, but you have 5-6 MCQ. Latz operation किसके लिए करते हैं? ये भी सवाल आ चुका है. Malrotation. Latz operation अभी आगे मैं बताऊंगा. Now this is a very very important X-ray. बहुत important है. Air below diaphragm and obstruction. ये वाला red zone का X-ray है, ये वाला green zone का है. Means this is supine. First one is erect, second is supine. This is multiple air fluid level suggesting obstruction. and here this is dilated colon. The supine tells you the site and diagnosis both. The site and obstruction and diagnosis, while erect only tells you the diagnosis by air fluid level. So the diagnosis is confirmed in supine by diameter. Small intestine diameter more than 3 centimeter. Large intestine more than 6 centimeter. And cecum more than 9 centimeter. So more than 3, more than 6 and more than 9, this is obstruction. How you know the site where it is? If you have a feature like this is colon. Why colon? Peripheral plus hostra. So colon has hostra, colon is peripheral, small intestine is central. How to differentiate jejunum from ileum? Here. So these are the air fluid level, multiple air fluid levels, step ladder pattern, very important X-ray. And this is the supine view. If I magnify, I'm sure you can see certain lines here. That's jejunum. No line here, that's ileum. So this part is jejunum, this part is ileum. The red part is ileum. And these lines are called volvuli conniventis. So till what point I see the air, like here, I see the air going here and ending here. Where this is ileum, there's no hostra. So I can tell you, yeah, this is the ileal obstruction. Distal ileum. अगर मैं हवा यहीं तक देख पाता, ये नहीं दिख रहा होता, तो मैं कहता it's a jejunal obstruction because I can see the volvuli conniventis and I cannot see the ileum. But in this X-ray, I can see the ileum. So site of structure is not important. You have a question in 2021 NEET. They showed X-ray and asked the site, but it's not important. Air fluid level is very important. So supine view, I told you, green zone may come in exam less likely. Erect is very, very important. Red zone. Multiple air fluid level, anybody can identify. Anybody, not even a doctor. आप 2-4 X से किसी को दिखा दो सड़क चलते वही पहचान लेगा हाँ भाई ये air fluid level है. So you can definitely identify obstruction in erect view. In supine, you can see dilated bowel, but you can see the site also. Like here, this is volvuli conniventis, and that is the transverse lines, right? Jejunum. Now, Ogilvy syndrome. What is Ogilvy syndrome? Ogilvy syndrome is small intestine 3, large intestine 6 and cecum 9. So, jejunum has volvuli conniventis, the transverse line, ileum doesn't have. This condition is the ileus of the colon. The colon loses its peristalsis. When it loses its peristalsis, it simply dilates and goes in obstruction. No mechanical obstruction, no stricture, no volvulus, no cancer, nothing. So, a dilated colon and obstruction, and I can see air up to cecum is Ogilvy syndrome, non-mechanical obstruction. No obstruction. Ogilvy syndrome. Parasympathetic suppression, sympathetic stimulation causing ileus. Cecum gets the maximum, all the back pressure goes to cecum, so cecum dilates and finally ruptures. So in Ogilvy syndrome, what happens? Non-mechanical obstruction of colon. The colon gets hugely dilated. Obstruction, because there's no peristalsis, no mechanical obstruction. The cecum is dilated maximally, finally perforates. And neostigmine is a non-surgical treatment. We cannot do surgery, there's no obstruction. Neostigmine is drug of choice, which prevents and which suppresses cholinesterase and increases the level of acetylcholine and increases the motility. So neostigmine is a drug of choice. Okay? And this is an important topic. Hang? No, there's no hang here. Must be at your end, Yash. Now, this X-ray is not very important. Air fluid level Amrut in children more than 5 and an adult more than 3 is considered significant. So in children more than 3 and adult more than, in children more than 5 and adult more than 3 is obstruction. So, ये जो X-ray है, ये बहुत इंपॉर्टेंट नहीं है, इसको मैं ग्रीन जोन में रखूंगा. यू कैन सी द कोलन इज लुकिंग लाइक ए थ्रेड, है ना, जैसे धागा है. कोलन ऐसा थोड़ी दिखता है, कोलन लुक्स लाइक दिस, एंड हियर यू हैव ए थ्रेड लाइक कोलन. दिस इज कॉल्ड माइक्रोकोलन, माइक्रोकोलन और क्वेश्चन मार्क साइन. सो दिस इज नॉट ए वेरी इंपॉर्टेंट एक्स-ray, but still one should know. The most common cause of microcolon is cystic fibrosis seen in meconium ileus. So this is a finding of meconium ileus. Although you may get this in other condition like complete Hirschsprung disease also, but that's very rare. तो पहला तो ये एक्स-रे आने का चांसेस बहुत कम है. लेकिन अगर आता है तो आपसे थ्योरेटिकली आएगा क्वेश्चन मार्क साइन और माइक्रोकोलन कहां मिलता है, थ्रेड लाइक कोलन. इट द आंसर इज ऑलवेज मेकोनियमाइलस सिस्टिक फाइब्रोसिस. ओके, now this is a very simple question. They show a image and ask what it is, or they show after surgery which consultation will be required. You have to refer him to Dr. Sachin. This is a psychiatric problem. So this is trichobezoar, the hair ball in the stomach. If it extends into the jejunum, then you call it Rapunzel syndrome, which is a 2021 INICET question. What is Rapunzel syndrome? Rapunzel is a fairy tale story. I'm sure you know. Let's say Snow White की story है ना, वैसे ही कि there's a princess having long beautiful hair. So this is basically common in young female less than 20 years. 10 से 20 साल के बीच में. They pluck hair and eat hair. तो क्वेश्चन में एक हिंट होता है patchy alopecia. Why patchy alopecia? They pluck hair. And finally they come with a lump and obstruction. Most common presentation, obstruction. So treated by surgery. This very big lump, you cannot remove endoscopy. So it's a trichobezoar, which is hair ball in the stomach, treated by surgery followed by psychiatric evaluation and treatment. Okay. Now this is a thumb printing in barium enema. Again important X-ray. The two most common, it can extend up to jejunum. It can go up to jejunum through the So two sites of ischemia in colon. One is splenic flexure called Griffith point. Why Griffith point? Why it's prone for ischemia? It's a watershed area between superior and inferior mesenteric artery. Superior mesenteric artery supplies till the right to the transverse colon. Inferior mesenteric starts after this. तो दोनों के बीच का एक junction होता है, तो ischemic होता है. इसे हम कहते हैं Griffith point. This is the most common site for ischemic colitis. Second most common site is Sudic point, rectosigmoid junction. So these are the two common sites for ischemic colitis, and the X-ray finding is thumb printing, which again I wouldn't say very important, but yes, you have questions on thumb printing also. Now this is the accordion sign seen in pseudomembranous colitis. And this is the target sign. देखो target sign you get in half dozen condition in abdomen. You get in CHPAs, you get in appendicitis, you get in Crohn's, you get in liver secondaries, many conditions. CT scan में target sign in intestine is due to bowel edema that you get in venous thrombus. I have few one-liner MCQ for you. What is the most common cause of mesenteric ischemia? So, yeah, they are not specific. Thumb printing is not specific for one condition. You can get thumb printing in other condition also. But most common is mesenteric ischemia. So, most common cause of mesenteric ischemia? Embolus. That's the question number one. No, sawtooth is different. मैं आपको sawtooth अभी दिखाऊंगा. I have X-ray shot. This is inside the lumen. हाँ, ये lumen के अंदर है. और sawtooth जो है ये बाहर होता है. ये bowel है. Sawtooth will be here. And this is inside the lumen. So most common cause is embolus. Okay. Arterial thrombus, venous thrombus, and non-occlusive rare. Number two, which of the mesenteric ischemia, which artery is most commonly involved? Superior mesenteric artery. Superior mesenteric artery. Number three, there is a condition called non-occlusive mesenteric ischemia, NOMI. Here you have sausage sign. Sausage sign. So superior mesenteric artery is the most commonly involved artery. Embolus is the most common cause. In non-occlusive, you have sausage sign, and in venous thrombus, you have target sign. You see, these are the bowel edema giving a target appearance. So in venous thrombus, target sign. In non-occlusive, sausage sign. Most common artery, superior mesenteric artery. Most common cause, embolus. These are some common questions they do ask. Comb sign and target sign you get in Crohn's disease. See the mesentery, see this area here, as well as here. Here, this is comb sign. So comb sign and target sign, both. In interception, yes, we do call it target sign or donut sign. And there also you can get in ultrasound. Here it's not ultrasound, this is CT. Sandwich or hamburger sign, mesenteric lymphoma. ये मैं छोड़ देता हूँ, ये important नहीं है. Now, diaphragmatic hernia, string sign of Cantor you get in Crohn's. Crohn's, they are totally different. So, NOMI stands for non-occlusive mesenteric ischemia. No thrombus, no embolus, but the flow is poor, so there's ischemia, non-occlusive mesenteric ischemia, NOMI. Where is target? अरे इसमें target नहीं दिखाई दे रहा तुमको, गोल गोल target दिखाई दे रहे हैं 3, ये bowel edema है. This is target. So you see, diaphragmatic hernia, there are 2 types. One is, देखो क्या होता है, in fetus, in diaphragm we have certain holes, we call it pleuroperitoneal canal, and they obliterate by the end of 10 weeks of intrauterine life. So if pleuroperitoneal canal persists, they become a hernia. So diaphragmatic hernia is persistence of pleuroperitoneal canal. Left side posterior, which is most common, is Bogdalek, 95%, right side NTM or Gagny. ये आप foot end से देख रहे हैं, नीचे से देख रहे हैं. So this is left side posterior Bogdalek, right side NTM or Gagny. And what is the presentation? This again is a red zone X-ray for you, very important X-ray. They will show when you find no air in the bowel, in the abdomen, where the air is, in the thorax, the intestine in the thorax, and the heart is shifted to the other side. So you find a scaphoid abdomen, intestine in the left thorax, and the heart is shifted. It's not a dextrocardia, it's pushing the heart. So this is a classical diaphragmatic hernia, very, very commonly asked. Number 2, Bogdalek is common type. And the main cause of death is pulmonary hypoplasia and pulmonary arterial hypertension. So pulmonary hypoplasia and arterial hypertension is cause of death. Number 3, it's again not a surgical emergency. Never operate immediately. Morgagni presents later on in adults. Morgagni is not a menace. Only Bogdalek is. It presents at birth. So Morgagni presents, and here the most common content is colon. That's another question. What is the most common content in Morgagni hernia? Colon. So you see, in Bogdalek, never operate immediately. First let the lung become mature. So you can wait. Time of surgery is not important. That's a question actually, which of the following is false statement? One option, immediate surgery done. No, we don't do. Number 4, don't give pressure ventilation, you will rupture. There's no space for the lung to expand. The intestine is occupying the space. So pressure ventilation is contraindicated here. You give ECMO, extracorporeal membrane oxidation. Yeah, target sign is seen in Crohn's also. Target and cone sign both. So these are sometimes question that they do ask. Most common type, Bogdalek, left side posterior, right side anterior Morgagni, which presents in adult. And you will find scaphoid abdomen. And the cause of death, the patient comes with respiratory distress. The child born with respiratory distress, not abdominal sign symptom. And heart on the other side. And pressure ventilation is contraindicated. Surgery is done after lung maturity. So this is what they do ask. This is the apple core sign, which some of you were confusing. There's nothing to confuse here. Any bowel having a growth like this will cause apple core. See, this is apple core. Colon cancer or esophagus, more often colon. And I don't even need to tell you why this is called apple core. The diagram, the photo is self-explanatory. Another sign is apple peel sign. Please don't confuse apple core with apple peel. Yes, esophageal cancer can also cause apple core. Any tubular structure can cause apple core, but most commonly seen in colon cancer, more common than esophagus cancer. Thoracotomy, diaphragmatic hernia, sorry, you have written thoracotomy or laparotomy. Diaphragmatic hernia is always repaired from the abdomen. Laparoscopy or laparotomy, not by thoracotomy. So diaphragmatic hernia and diaphragmatic injury in adult approaches abdominal, not thoracic. Okay? No, string sign is a long sign. String sign will be long. ये apple core को string कैसे कह सकते हो? String तो लंबा होगा ना? तो जब कोई चीज के नॉर्मल से ज्यादा लंबी होगी, जैसे पार्लर से दिस मच लंबी होगी तो स्ट्रिंग साइन बन गया. इंटेस्टाइन में पतला धागा हो गया. So it's a string sign. Okay? Apple core sign you see in type 3 bowel atresia, 3B bowel atresia. So this question has already came once. It has been asked once only. So I won't say that apple peel sign, where do you get? You get in type 3 bowel atresia in barium study. So I will not say it's very important, but already it has been asked once. So I'm just telling you that this should not be confused with apple core. So I'm telling you apple peel is different, apple core is different. Now this is a claw sign. Yes, bowel atresia classification 4 types you must know. There are questions. And this is a last year question of NEET. Last year only they showed clause sign. This is a clause sign. These are clause sign. And where you get clause sign? In intussusception. So intussusception, the sigmoid volvulus, I will tell you. We have a question on sigmoid volvulus, so I'll tell you the rotation. So clause sign basically intussusception, and the intestine goes into the intestine. Most common age 6 months to 1 year. And most common cause Peyer's patches enlargement. So weaning. So weaning and Peyer's patches hypertrophy, most common age and cause. Most common type ileocolic. Ileocolic, most common. And ultrasound gives target sign and pseudokidney sign. Barium enema gives clause sign and coiled spring sign. Coiled spring sign more often you get in hematoma, bowel hematoma. So apelcoricin in cancer, any tubular hollow structure cancer like colon or esophagus. Yeah, rotavirus vaccine again can increase the Peyer's patches and can cause intussusception. But most common cause is weaning. Ileocolic is most common type, and age of weaning is most common age. Presentation only 3. Number 1, red currant jelly stool. And please write the current spelling C-U-R-R-A-N-T, not C-U-R-R-E-N-T. It's not a current electricity, red currant. It's a fruit, red currant jelly stool. Number 2, a sausage-shaped lump with concavity towards umbilicus. And number 3, empty right iliac fossa called Dahn's sign. So Dahn's sign, empty right iliac fossa, sausage-shaped lump with concavity towards umbilicus, and red currant jelly stool. These are the 3 classical features you get here. The pain will be, of course, there, colicky pain. Intussusception presents with pain. The pain will be intermittent. The child will, it's not a continuous pain, intermittent colicky pain. So the child will cry, then he's comfortable, then again cries. So pain, of course, is a part of intussusception. So this is the X-ray, and the treatment is first, you order, so there's some problem, right? It's not, so it's becoming big and small. What is happening? इसमें कुछ हो गया, ये बड़ा छोटा हो रहा है, ऊपर नीचे नहीं जा रहा, but anyway. So treatment is first you go for barium enema reduction or hair reduction. If it fails, you can do laparotomy. And the gangrene starts from the tip of intussusception. Like this is the intussusception. Here, the gangrene starts from here, from the tip. Okay. Let me call someone because I'm stuck with this. It's becoming big and small. Not actually going down. एक बार ना ये देखना, ये छोटा बड़ा ही हो रहा है, ऊपर नहीं, जिसमें ऊपर करना चाहता हूं ना, फिर भी ये जूम इन जूम आउट ही हो रहा है. नहीं, मैं ऊपर भी कर रहा हूं, देखो मैं ऊपर भी कर रहा हूं ना, फिर भी वो जूम इन जूम आउट ही हो रहा है. इसमें कुछ फंस गया ये कुछ. सो यू सी, एक बार देखना इसको. हाँ, हाँ ठीक है. No, bowel atresia is not a very important topic, but you have question. I mean, something which you cannot, I'm not saying it's as important as intussusception or Mickels, and those are very important. Zenker and all those are important, but yes, you have questions. So, now, diverticulum Mickels, as you already know, it's a congenital diverticulum. It's a persistence of vitellointestinal duct. Ileum is connected to the umbilicus before birth, and by 6 weeks of intrauterine life, the duct connection disappears. So this is the umbilicus, this is the intestine, and this is the vitellointestinal duct. अगर इसका proximal part रह जाए ना, तो एक diverticulum बन जाता है. So remember what is diverticulosis doesn't have red currant jelly stool. Diverticulosis are fresh bleeding, absolutely fresh. So, अगर proximal part इसका रह जाता है, that is the Meckel. So and remember the proximal, that's the Ames question. So Meckel's is persistence of vitellointestinal duct proximal end. Number 2, very often it has ectopic tissue, stomach and pancreas. Remember both, not just stomach. Remember stomach and pancreas, that's the last year question. So stomach and pancreas, both ectopic tissue you may get. More often stomach, 50% stomach, but really pancreas. Number 3, the main presentation is bleeding. In children, it presents with bleeding. In adult, presents with obstruction. Number 4, the diagnosis of ectopic tissue is technetium scan. So this is the stomach, this is the urine in the bladder, and this is Meckel. So if ectopic tissue is there, technetium scan is very good. The accuracy can be increased by pentacrystine, cimetidine, or glucagon. But if ectopic tissue is not there, technetium has no role. Then we go for barium study, contrast study. So this is the contrast study. You can see Meckel's. Plus intraoperative. You have questions image based also. So Meckel's is a congenital diarrhythlum, 2 inches long, 2 feet proximal to alocycal junction, 2% incidence. Male-female ratio 2:1. If ectopic tissue is there, it will definitely present with bleeding, always needs treatment, resection and anastomosis. But if no ectopic tissue, you can do diverticulectomy. So these are the important point about Meckel's. Okay? Intussusception can be caused by Meckel's. So this is sigmoid volvulus. Coffee bean shaped shadow, very, very important X-ray, is a dead zone X-ray for you. So this is a coffee bean shaped shadow or inverted U shaped shadow. These are sigmoid volvulus. Generally, whatever I said is written there, you can read it later on. Generally, this is the sigmoid. The volvulus goes like this, here. What is this direction? Anti-clockwise. So, hernia of Meckel's is called Litter's hernia, L-I-T-T-R-E, Litter's hernia. So, normally sigmoid volvulus is anti-clockwise, but rarely it can be clockwise also. So, sigmoid volvulus can be either side, anti-clockwise or clockwise, but anti-clockwise is much, much more common than clockwise. But cecal volvulus is only and only clockwise. So sigmoid can be both anti-clockwise and clockwise. The first one is anti-clockwise, second is clockwise. But cecal always clockwise. Sigmoid also more common anti-clockwise. So this is a inner bend tube, Freeman-Dahl sign, coffee bean shadow. There are many words for omega sign, inverted U sign. Many words used here. Remember coffee bean shaped shadow. Very, very important X-ray for you. This is the bird beak sign in barium enema in sigmoid volvulus. Sigmoid and cecal both give bird beak sign. This is a cecal volvulus bird beak sign here. So, and this is the diverticulosis, sawtooth appearance. What you want to know? Difference of sigmoid and cecal. Okay. देखो sigmoid volvulus जो है, मैं फोटो भी दिखा दूंगा. ये इस तरह से होता है, ऐसे. सीकल वॉल्वस जो है ये इधर होगा. प्लस सीकल वॉल्वस ऑलवेज, बट सीकल वॉल्वस विल बी स्मॉलर, मोर कॉन्वेक्स, मोर किडनी शेप्ड, मोर राउंडिश, एंड सिग्मॉइड यूजुअली ऑन द लेफ्ट साइड, on the right side, but even on the left side, this will be much bigger and oblong. The shape will differ. So you can differentiate between the two. But cecal volvulus, normally they don't ask, they only ask sigmoid. And if it's tilted on the right side, without doubt it's sigmoid. Only when it's tilted on the left side, then you may have confusion between the two. But cecal will be more roundish, more kidney shaped, more comma shaped. Cecal is called comma sign. It's like this, comma sign. Sigmoid volvulus, if there's no gangrene, you should pass a rigid sigmoid. I'm repeating, rigid sigmoidoscope and derotate it. Otherwise, if it fails, do laparotomy and manually rotate. And if there's a gangrene, the word is Hartmann's, not resection and anastomosis. You do resection and Hartmann's procedure. So resection and Hartmann's procedure is found in sigmoid, is done in gangrene of sigmoid volvulus, not resection. Hartmann's procedure done for gangrene of sigmoid volvulus. Otherwise, simply derotate and fix. This is the diverticulosis. Investigation or choice of Meckel's, if someone says, say technetium scan. But if I specifically say there's no ectopic tissue, then you say contrast study. Barium will follow through or CT enteroclysis. So, technetium is an investigation, but only when ectopic tissue is there. If it's not there, then contrast study. So this is the same slide, irrelevant slide. I don't know why you're asking such kind of question. Same slide is very old slide. It has no clinical significance. Diverticulosis, hiatus hernia, and gallstone. These are irrelevant slide. Don't worry about it. And there's a last page on child only. I'll tell you all this later on. Don't interrupt in between. So this is the sawtooth appearance of diverticulosis seen in old age, most common site, bleeding, and sigmoid. So Hinche classification is an important classification. They do ask this, and the bleeding is from the branches of superior, although it's common in sigmoid, but the bleeding is common from the right colon. So it's a question, which artery bleeds in sigmoid volus? The artery which bleeds in sigmoid volus is superior mesenteric artery, because the bleeding is more common from this side. So it's superior mesenteric branches. Diverticulosis is more common on this side, but they cause diverticulitis. They don't cause bleeding. Left-sided diverticulum cause colitis and right side cause bleeding. So superior mesenteric artery bleeds. Hinche classification I'll leave. You have to read, but there are questions on this. Now some surgery. Dolman operation. Simply cut the in-between septum with the help of stapler. That's for, I'll take another 15 minutes and I'll finish. So Dolman is basically a surgery for Zenker diverticulum. Fokker, only remember the name, for type A atresia. Diverticulosis investigation first is colonoscopy first, and best is barium enema, which gives sawtooth appearance for diverticulosis. For diverticulitis investigation is CT scan. So for diverticulitis, go for CT scan, and for diverticulosis, first we order colonoscopy, but best is barium enema, which will give sawtooth appearance. So Fokker is only for type 1 atresia. Only remember the name. That too is not very important. Heller's myotomy, already you know, cutting the sphincter muscle. Only cut the muscle. Don't get a perforation. This is done for achalasia cardia, and it will lead to reflux. So you can add DOR fundoplication. Now this is Ramstead palmomyotomy. These are the important surgery name you remember. Only cut the muscle, don't cut the mucosa for CHPS. This is horizontal incision, transverse, vertical incision, doing a duodenoscopy in duodenal atresia called Kimura operation. Okay, the name is not important, but remember duodenoscopy for duodenal atresia. Now this is the LATS operation done for malrotation. You do 3 steps here. Cut the LATS band, bring the cecum to the left side, that's called widening of mesentery, and do prophylactic appendectomy. The steps, no question on steps, but I'll tell you 3 steps. Only one question asks, LATS operation is done for what? LATS operation is done for malrotation. What we do in LATS operation? Cut the LATS band, so relieve the obstruction of duodenum, take the duodenum cecum to the left side, widening of mesentery, and do appendectomy. These 3 steps are called LATS operation. Cutting the LATS band, widening of mesentery, and appendectomy. This is LATS operation for malrotation. This is Bishop-Koop operation. No, Nissens we don't do. Nissens is complete fundoplication. So we do partial DOR. If I do complete fundoplication, I will make the surgery futile, because fundoplication will close the sphincter again, which already I have cut. So I don't want to close the sphincter, I just want to tighten the sphincter. So we do partial fundoplication, no Nissens. After achalasia surgery, if I cut the sphincter and make it strong, by cutting I'm making it weak, and again making it strong by Nissens. So what's the point of cutting the sphincter? So we only do partial, no Nissens, only DOR. So DOR is actually 180, not 270, but anyway. So this is called Bishop-Koop operation. This is a surgery for meconium ileus. What point we need to know about meconium ileus? Meconium ileus is a surgery, is a condition seen in cystic fibrosis, where the meconium is very, very thick like a jelly. It is very viscid, precipitates in the bowel and obstructs the bowel. So this condition presents with antenatal perforation called meconium peritonitis. You know, meconium peritonitis is antenatal in the fetus only. Meconium comes out in the peritoneal cavity of the fetus, gets calcified. That's called meconium peritonitis. So meconium ileus can cause obstruction, meconium peritonitis, pseudocyst, afterbirth, many things. So cystic fibrosis, which is autosomal recessive, the meconium precipitates in bowel, causing meconium ileus or microcolon. I showed you the image earlier. Now, in X-ray, you don't get air fluid level, rather you get soap bubble appearance. which is called Neuhauser. Neuhauser. So in X-ray you get Neuhauser sign, Neuhauser. So this is a X-ray finding of meconium ileus, where in obstruction you don't get AF fluid level. What do you get? Soap bubble appearance. What is the treatment for meconium ileus? First we go for gastrographin enema. Gastrographin enema. Why gastrographin enema? It is hyperosmolar. It can dissolve the meconium, that thick jelly-like meconium, and relieve the obstruction. And how many gastrographin enema attempt can be made? 2. Twice it can be given. So give gastrographin enema twice. If it relieves obstruction, good. Otherwise, do Bishop-Koop operation. So Bishop-Koop is a surgery where I do ileostomy temporarily. The distal segment comes out proximal to distal eye, anastomos end to side. This is called Bishop-Koop. So Bishop-Koop operation is done for meconium ileus. Okay, so these are the salient features you need to remember about meconium ileus. So this name is not important. I will keep this in black zone. Still, I'll tell you the name. I doubt कि इस पे सवाल आएगा. This is called Cono S anastomosis. This is only and only done for stricture in Crohn's disease. So stricture in Crohn's disease, we do Cono S anastomosis. Okay, if you remember the name, it's okay. You can skip this. It's not important. Now, surgery for pyelonephritis sinus, only remember the name. Photo will not come. One is called Bascom. Bascom is a specific surgery only done for pyelonephritis sinus. Second is Caridakis. So Bascom and Caridakis. Bascom and Caridakis are 2 surgery done only for pyelonephritis sinus. Romberg or Limburg or rhomboid flap. This one is not for pyelonephritis sinus specifically. This is the plastic surgery done at many places. So this image, rhomboid flap, has already come in exam. Not the same image, but there's a flap and they ask what is the name of this flap. This is called rhomboid or Limburg flap. So Limburg flap, Caridakis and Bascom are basically surgery for pyelonidal sinus. What is short bowel syndrome? When the length of bowel becomes very short. When the length is less than 200 centimeter, we call it short bowel syndrome. Presents with malabsorption. Most common cause medically Crohn's, surgically mesenteric ischemia. So Crohn's is the most common cause, followed by mesenteric ischemia in surgical cause. And how it presents? Malabsorption. So it will cause malabsorption and gallstone cholesterol type and oxalate stone renal stone plus hypergastrinemia. Yeah, these are cutaneous flap, not myocutaneous. You don't take muscle here, only skin and fat. Angiodysplasia, most common site is right colon, ascending colon and cecum. So hypergastrinemia and peptic ulcer are seen in short bowel syndrome, which is a MCQ. The question was, which of the following is not a feature of short bowel syndrome? And the options were atrophy of the bowel mucosa, gallstone, and one option was hypogastrinemia. No, we don't get hypogastrinemia, we get hypergastrinemia. Most common cause is Crohn's, which is medical. Second most common cause is mesenteric ischemia, which is surgical. So when the length is very short, you have cut and removed the bowel, it is less than 200 centimeters, you call it short bowel syndrome. 2 surgeries and presents with gallstone, malabsorption, diarrhea, steatorrhea, hypergastrinemia, gallstone and renal stone. Which type of gallstone? Cholesterol stone due to bile salt deficiency. Which type of renal stone? Oxalate. So 2 surgeries, one is called Bianchi operation and second is called STEP. These are 2 surgery for short bowel syndrome. You can see you make incisions and it is increasing the length of the bowel, the surface area. Now, rectal prolapse surgery, the image came last year in your NEET exam, where they're not the same image. A surgeon has given an encircling suture, finger anal canal, he's tightening the suture and they ask what surgery is this. This is called Thiersch operation, only done for partial prolapse. For complete, we don't prefer. Very good, poor result. So only for partial, old patient, sick patient, not fit for. It can be done under local anesthesia. That's the biggest. Teduglutide increases the villi length. So it increases the surface area. So it increases the length of villi. Teduglutide. That's a drug of choice. So this is the this is the Thiersch operation. Another surgery is called Delorme, where you plicate the rectum which is coming out. Another surgery is Altamir, where you excise the rectum which is coming out. These three surgeries are basically done from perineum. So perineal approach of prolapse are Thiersch, Delorme and Altamir. And abdominal approach are rectopexy, Ripstein and Wells and Dehour. In Ripstein, as you can see, we fix from the abdomen side, fix the rectum posteriorly to the sacrum, and in Dehour, we fix anterior to the anterior denonvular fascia. So this was a question of inicet this year, that which rectal prolapse surgery is not done from the abdominal, from the perineal route. And the options were Thiersch, Delorme, Altamir and Ripstein. So Ripstein is done by the abdomen. Abdominal route, two surgeries are Ripstein and Dehour. Dehour में आगे लगाते हैं ventral mesh rectoplexy and Ripstein में पीछे लगाते हैं. So in Ripstein you fix the rectum with the sacrum, and in Dehour you fix anteriorly. Okay, these are abdominal approach. The names only you remember, photo will not come in exam. Now just next two slides. देखो, this is the rectum, anal canal. Any cancer which goes above 5 centimeter from anal verge is treated by anterior resection, which is resection and anastomosis with a 2 centimeter margin. Any cancer which comes within 5 centimeter like here is treated by APR. Rectopexy have less recurrence rate but more side effects. So rectal cancer, two surgeries, APR and AR, abdominoperineal resection and anterior resection. How to differentiate between the two? APR means the cancer should be within 5 centimeter, AR means above 5 centimeter. So this is the cancer where I'll cut here and anastomose. This is AR. When I'll do this, from the anal verge, it should be more than 5 centimeter or from dentate line 3 centimeter. But in case the cancer is very close to anal verge within 5 centimeter, then I excise the whole area and make a permanent colostomy. That's called APR, abdominoperineal resection. So within 5 centimeter, above 5 centimeter. This is how you differentiate. And from dentate line 3. To mobilization of colon. When I mobilize ascending colon, making incision here, reflected to approach vena cava, right kidney, right hemicolectomy, we call it Kettle-Barash mobilization, right medial visceral rotation. And when we make incision on the left side, mobilizing the APR, full form is abdominoperineal resection. Abdominoperineal resection. So the left medial rotation is called metox. See, so I simply make incision here and mobilize like this to approach vena cava, right kidney or right hemicolectomy. Then I call this Kettle maneuver. And what is the misprinting? Yeah, there's a misprinting. You are right. Here there's a misprinting. So here there's a misprinting anterior. This should be APR. APR. So that is a misprinting. Now, the left mobilization like here, this is called metox. Metox is for aorta, for left kidney, for right here. This is Kettle and this is metox. And yeah, so corrected. There's a misprinting, you are right. And the mobilization of duodenum is called Cockerization, Cocker's maneuver. Cocker's maneuver. So APR is abdominoperineal resection, okay? From the dentate line 3 centimeter, from anal verge 5 centimeter, more than 5, less than 5. So less than 5 APR, abdominoperineal resection, more than 5 AR. And behind the rectum, till This is the presacral fascia and this is the levator ani. So I am writing LA for levator ani, I am writing fascia for presacral fascia. All the tissue in between is called mesorectum. So when we do AR or rectal cancer, this whole mesorectum needs to be removed. So don't go behind the fascia, don't go in the presacral space. This space will be presacral space, don't go in this space, but go up to the fascia and remove all the mesorectum. This is called mesorectum. So, what I said, अगर हमें कोलन को मोबिलाइज करना है, ascending colon ko, so I make incision here and reflect. See this image, I have reflected the colon. Only then I could reach the right kidney and vena cava and right hemicolectomy. This is called cattle maneuver. क्योंकि ये फिक्स स्ट्रक्चर है, मोबाइल नहीं है, इसको मोबिलाइज करना पड़ेगा. एंड इफ आई हैव टू मोबिलाइज द डिसेंडिंग कोलन लाइक दिस टू रीच आयोटा और लेफ्ट किडनी, देन आई से मेटॉक्स मैन्यूवर. So mobilization of the descending kidney is metox, left medial rotation, and for right side, right medial ascending colon is cattle barrage. And mobilization of duodenum is called Cocker's maneuver. Cocker, K-O-C-H-E-R, Cocker's maneuver. So duodenal mobilization is Cocker's. Content of mesorectum are, Cocker is mobilization of duodenum, duodenal mobilization. Like this is the stomach. And this is the duodenum. Now, if I make incision here and mobilize the duodenum, then that's called cockerization. Okay. So, content of mesorectum are lymph node, fibrofatty tissue, superior rectal artery, and inferior hypogastric plexus. So, we have to go a little fast. So, you can see the video and write down later on. Superior rectal artery, lymph node, inferior hypogastric plexus, and fibrofatty tissue. This is the content of mesorectum. So, देखो ये नया ट्रीटमेंट है CRS and HIPEC. You see, this is for peritoneum. When we have a cancer in the peritoneum, like mesothelioma or pseudomyxoma peritonei, or colon cancer secondaries, which is inoperable, M1C. So what we do? Yeah, mesorectal excision done in all cases when you are operating rectal cancer. AR, if you are doing, mesorectum completely should be removed. Don't leave a part of mesorectum, otherwise you leave lymph node and will have higher recurrence. So removing mesorectum reduces the recurrence rate. So, what I was saying, कि when you have peritoneal secondaries, just operate and remove all cancer whichever is possible, whatever you can remove. So you know you cannot remove the complete cancer in abdomen, it's already peritoneum spread, but whatever possible you remove. So you do a R2 resection. R1 का मतलब, R0 का मतलब no residual disease left after cancer surgery, R1 का मतलब microscopic, R2 मतलब gross. So I know that there are so many cancer in peritoneum, I could remove most of them, but some are left behind. No problem. We have done a cytoreductive surgery, means we have reduced the volume of the cancer. Then we put a catheter in the abdomen and instill the chemotherapy at 42 degrees centigrade. So you put the chemotherapy in the abdomen, and for that what term we use? Hyperthermic, temperature more, intraperitoneal chemotherapy. So hyperthermic intraperitoneal chemotherapy after surgery is done for peritoneal secondaries and primary. This is the most common, most accepted surgery for mesothelioma, for pseudomyxoma peritonei, and peritoneal secondaries from ovary, from uterus, from colon, etc. So do surgery, instill abdomen with chemotherapy at 42 degree for 1 to 8 hours. 2-3 hours the chemotherapy will circulate in abdomen at 42 degree. This is called HIPEC, done for mesothelioma or peritoneal secondaries. Okay? Hyperthermic intraperitoneal chemotherapy. Now, papillon therapy is a new technique, not being done in India, but it's given in Love and Bailey, may become a question. Unlikely, but may become a question. This is the R1 means microscopic disease left here. After surgery, no disease left, R0, microscopic R1, gross disease R2. So there is a cancer here. I will put a probe in the rectum and this probe has chemotherapy. So what is agent used is written here, bhai. It's written here. Not written? Okay. Generally we use the same chemotherapy, mitomycin C, cisplatin, what we use otherwise. So I will, the chemotherapy is in the probe. It's a contact, not chemotherapy, radiotherapy. So it's a contact radiotherapy for the colon, not chemo, sorry, that was the important, radio. So this is a contact. 42 degrees centigrade will not burn the abdomen. It's 42 degree. It will not burn the abdomen. So radiotherapy you give directly on the cancer, contact radiotherapy, and this is called papillon therapy. Only radio for early rectal cancer. TIS and T1, that's up to submucosa, and node negative within 3 centimeter size. So papillon therapy is a brachytherapy, contact radiotherapy for early rectal cancer, not being done in India, but given a love and belly may become a question. It's not R1, R2, R3, it's R0, R1, R2. R0 is no cancer left after surgery. R1 is microscopic disease left, R2 is gross disease left. Okay? Now another treatment is Nigro regime. This already has been asked 3-4 times. This is the rectum. This is the levator ani. This is the puborectalis. No, for prostate we don't use HIPEC. No, not for liver, not for pancreas. Liver and pancreas are high grade cancer. They don't respond. And prostate it's not needed. But for appendix it can be done. For colon it can be done. You see. So this red is puborectalis, this blue is levator ani, and rectum is from here to here. In the center there is a line called dentate line. Above dentate line, this is columnar mucosa having adenocarcinoma. Adenocarcinoma is treated by APR, abdominoperineal resection. APR. So above the dentate line, the cancer of rectum is adenocarcinoma from columnar, APR. Below dentate line, the mucosa is squamous. And this will have a squamous cell cancer. Squamous cell cancer is treated by NIGRO, Nigro regime. Nigro regime is chemo-radio. Squamous cell cancer is the most common cancer of the anal canal treated by Nigro regime. So Nigro regime is a very, very important regime. It has been asked many times. Nigro regime is used for what? Only for squamous cell cancer anal canal, and this is chemo and radio. First chemo, then radio. Don't say radio chemo. Say chemo, radio. Okay? So that's... Now this is a new drug, dostarlimab. This is approved for colon cancer which are DMMR positive. DMMR means deficient, mismatch repair. MMR stands for mismatch repair, and this is for why I am telling you only one antibody, why not other antibodies? So many antibodies have been approved in last 10 years. This is the only antibody which has given 100% response in colon cancer. So AR and APR both 5 centimeter. Below 5 centimeter APR, above 5 centimeter AR. But if I tell the distance from dentate line, then it is 3 centimeter. From the anal verge 5 and from the dentate line 3. So for PD1 and PDL1 positive colon cancer, DMMR, this is the only cancer, the only drug which is given 100% response. Hereditary syndrome we can leave, that's not, you can read that later on. In polyp, remember only 5-6 lines MCQ. Whenever you have an image like this, the whole the whole colon started with polyp and polyp and polyp and polyp, then the diagnosis is familial adenomatous polyposis. No, dostali map is not used for gist. इस तरह से सवाल से मुझे लगता है कि आप लोगों के कंसेप्ट ही क्लियर नहीं है. जिस्ट एक अलग कैंसर है, वो मसल से होता है, वो म्यूकोजा से थोड़ी होता है. तो लाइक मैं आपको पढ़ा रहा हूं, आप मुझसे मेनिंजियोमा बोलने लगे, तो मेनिंजियोमा अलग है ना. तो जिस्ट इज अ कैंसर ऑफ जीआईटी बट नॉट एडेनोकार्सिनोमा, नॉट स्क्वामस सेल, मसल से आता है, और ये कैंसर म्यूकोजा से आते हैं, टोटली अलग होता है. सो फेमिलियल एडेनोमेटस, तो आप लोगों ने रट लिया है, बट यू डोंट नो द कंसेप्ट की क्या क्या चीज है, फिर आपको कंसेप्चुअल सवाल करने में प्रॉब्लम आती है. सो द जीन इज APC on chromosome 5q, more than 100 polyps with 100% cancer risk. FAP is familial adenomatous polyposis. Familial adenomatous polyposis. APC gene, 5q chromosome, more than 100 polyp must be there to diagnose, and 100% cancer risk. The second most common cancer in FAP is periampullary cancer. In GIT, second most common periampullary. And extra-intestinal most common is papillary thyroid cancer. So, I think it must be written here. So, papillary thyroid cancer is most common extra-intestinal cancer. And then in retina, you can have a condition of pigmentation of retina called CHRPE, which stands for congenital hypertrophy of retinal pigmented epithelium. So I have told you 4-5 lines, these are MCQ. Line number 1, FAP is autosomal dominant chromosome 5q, adenomatous polyp, more than 100 polyps. Should be there. So whenever you have a picture like this is FAP. Number 2, the cancer risk is 100%. Second most common cancer in GIT in FAP after colon cancer is periampullary cancer. Extra-intestinal most common is thyroid papillary, and extra-intestinal manifestation is congenital hypertrophy of retinal pigmented epithelium and CHRPE. And other conditions of polyp which they ask, if you find multiple or brain tumors in polyp, there are brain tumors and polyp, colonic polyp, then this is Turcot syndrome. So Turcot syndrome is brain tumor and polyp. Number 3, if there is polyp and lip pigmentation, then this is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome. So, lip pigmentation. Peutz-Jeghers syndrome is autosomal dominant, chromosome 19, gene STK11. So, I'll repeat what I said. A polyp in colon, adenomatous, more than 100 is FAP, 100% cancer risk, autosomal dominant, chromosome 5q, gene APC. Second most common cancer in FAP is periampullary cancer. And most common thyroid cancer after this, second most common is thyroid papillary cancer. And in retina, one can get pigmentation, congenital hypertrophy of retinal pigmented epithelium. Periampullary is second most common. In brain tumor and polyp adenomatous, it's Turcot. And if there's a pigmentation and polyp in colon, it's Peutz-Jeghers. Peutz-Jeghers is hamartomatous polyp. So, hamartomatous polyp, which is written here, are basically Peutz-Jeghers, Cowden, juvenile polyposis. These are hamartomatous, juvenile polyposis. So, hamartomatous, while Turcot, Cowden, Turcot, Gardner, FAP is adenomatous. And in juvenile polyposis, no, Peutz-Jeghers do not have CHRPE, FAP has CHRPE. So, in juvenile polyposis, there's no risk of thyroid cancer. Only in Cowden you have risk of thyroid cancer, that is follicular, and in FAP you have risk of thyroid cancer, that's papillary. So, follicular cancer risk is not in juvenile polyposis, it is in Cowden syndrome. Okay? Yeah, follicular and Cowden. Ronak, you are right. Now, this is a pigmentation with polyp, hematomatous, and one more word, arborizing pattern of fibrovascular core. So, if arborizing pattern of core is written, which is a 2021 inicet question, then this is Peutziger. Arborizing pattern. So, I'll simply repeat, SPAD4, SPAD2 is not really for juvenile polyposis, SPAD4 is for juvenile polyposis. Now, this I will simply leave, not needed. Yeah. So, this is a new treatment for carcinoid, which is Lu177 dotatate. Lutetium 177, which has a high beta emission. No, I'll not repeat it unless you are serious. I don't think you people are too serious, so I don't have to exert more for you. If you are casual, then I'm also casual. So, lutetium 177 has high beta emission, and this destroys the cell. And this is attached with dotatate. So, dotatate takes the lutetium to the tumor. मुझे ना इसका चार्जर दे दो, ये खत्म हो रहा है, फिर मैं पढ़ नहीं पाऊंगा क्या बच्चों ने लिखा. So, dotatate is combined with lutetium and given to the patient. The carcinoid which are SRS positive and carcinoid which are GIT, it is approved. Only for GIT carcinoid, SRS positive carcinoid. So, we can give lutetium dotatate, which is a new treatment for मैं भूल गया इसको चार्ज करना एक्चुअली. या बस ठीक है, चलो. So I'll simply repeat. You can see the first image and the second image. First image is the multiple secondaries in liver. Of course, it's inoperable. So for this, you have a new treatment, lutetium 177 dotatate, only for neuroendocrine tumor, GIT tumor. For pancreas, for liver, for GIT, again used, not for carcinoid in respiratory or genitourinary. And it has a high beta emission, so it destroys the tumor. This is for SRS positive tumors only. SRS positive means somatostatin receptor scintigraphy. Somatostatin receptor scintigraphy. You have to know the staging of colon both TNM as well as Dukes. दोनों ही पता होनी चाहिए. In colon, both they ask, Dukes B or TNM B. This I think you can leave. You can read this part. It's only theory, but gist is a very, very important topic. I want you to read gist. The important points I've written here. So please do read gist. This also is basically theory. I'll just take 5 more minutes. These are some classification they have asked earlier. Nevin classification is for gallbladder cancer, not used anymore. Now we use TNM, but you have a question where they have asked Nevin kaha use karte hain. Dukes is for colon. You should know Dukes. Yes, पे भी सवाल आ चुका है. Sievert is for GE junction cancer. यहां पे जो कैंसर होता है जीई जंक्शन पे 13 सेंटीमीटर में, 5 इन द ईसोगस, 5 इन द स्टमक एंड 3 इन बिटवीन, उसके लिए वी हैव ए क्लासिफिकेशन सीवर्स. सीवर्ट इज बेसिकली इंपॉर्टेंट. द नेम, द डिटेल्स आर नॉट इंपॉर्टेंट. सो सीवर्ट इज फॉर जीई जंक्शन ट्यूमर, ड्यूक्स फॉर कोलन कैंसर, नेविन फॉर गॉल ब्लैडर. ड्यूक्स यू हैव टू नो इन डिटेल, नॉट रेस्ट. Rest only remember the name. Lorraine Borman Japanese for stomach. And ये आप छोड़ दो, ये नहीं पूछा जाएगा, ये आप हटा सकते हो. हिंचे, this I want you to know, this I want you to know, this I want you to know. These 3 you read in little bit of detail, rest only you remember the name. TNM in GIT, Meghna, only 2. One is colorectal cancer, second is gallbladder. So colorectal cancer and gallbladder, I want you to know the TNM. बाकी आप छोड़ सकते हो. In GIT, only 2. margin for cancers, 2 centimeter margin for rectum, gist and carcinoid, 2 centimeter for rectum, gist and carcinoid, 5 centimeter, ये हटा दो, इससे कंफ्यूज मत होना, 5 centimeter for stomach adenocarcinoma, 5 for colon also, and 10 centimeter for esophagus. So these are the safe margin for cancer. Rectum के लिए 2, gist और carcinoid के लिए 2, colon के लिए 5, stomach के लिए 5, and for esophagus 10. For gist, biopsy is very well taken. You take endoscopic ultrasound guided biopsy, EUS guided biopsy. You have a question. Whenever question says how you take biopsy from gist, how you take biopsy from lymph node next to esophagus or stomach, how you take biopsy from pancreas, for all answer is EUS guided biopsy, endoscopic ultrasound guided biopsy. This is a last year inicet question. Minimum number of node कितने होने चाहिए? How many should be the minimum number of nodes? So for stomach, it should be 16. For colon, 12. Gallbladder 6 and breast 10. This is the minimum number of lymph node you have to excise with the tumor. And margin, I'll repeat, for esophagus 10, for stomach 5. Like for esophagus, upper side 10, lower side 5. Once you go in the stomach, only 5. For colon 5. For rectum 2, gist 2 and carcinoid 2. Okay, this is the question. Gist ka margin kitna lete hain? I remember in guide it was written 1 centimeter, which is wrong. So, now you see, I will tell you the bariatric surgery salient feature. Okay, 3 compression syndrome. 3 compression syndrome. Dekho, this is the stomach and duodenum and this is the esophagus. Superior mesenteric artery goes like this from the anterior to third part of duodenum. So if I see the lateral view, stomach is more than 15 or 16. So either you say more than 15 women or you say 16. It's better you say 16. If you have to say one figure, say 16. So this is the superior mesenteric artery and aorta, and this is the duodenum. So if the angle here normally is 35 to 65 degree. Yes, forest you should read. Rockall, only remember the name. Don't read the Rockall. Rockall, remember, Rockall is done after endoscopy, Blatchford before endoscopy, forest during endoscopy. And in endoscopy, forest you should know. Blatchford and Rockall, no need to know the detail, no remember the name. So this is the normal angle. When the angle becomes less than 15, less than 25 is pathological, less than 15 the duodenum gets compressed. This is called superior mesenteric artery syndrome. You can see here where the duodenum gets compressed between aorta and superior mesenteric artery. This is common in thin young female. When the fat is very little, there's no support of the fat around the duodenum, then you can get this. Or even the abdominal cast also you can get this. Diagnosed by CECT. Remember, I'm repeating because I've seen many people say the diagnostic investigation is CT angio. No, that's wrong. No angio. CECT. We don't want to see vessel. We want to see compression of duodenum by vessel. So no CT angio, CECT is the investigation. And the treatment angle less than 25 abnormal, less than 15 diagnostic. It will cause compression and symptom. Bilious vomiting. Lean and thin young female. And CECT. And the treatment is conservative, just conservative, no surgery, just conservative. But if it doesn't relieve, then go for duodenojejunum. CVERT is for GE junction cancer, gastroesophageal junction cancer. So duodenojejunostomy can be done, or another surgery called strong operation can be done. So duodenojejunostomy is the treatment of choice for superior mesenteric artery syndrome. Strong operation is another operation can be done. But DJ is the surgery of choice, but not the first preference. First preference conservative. So angle here, this is the angle, this angle. Normal 35 to 65 degree. Less than 25 pathological, it will tell you that yeah, there's a problem, and less than 15 will have definite obstruction. So superior mesenteric artery syndrome. No, not gastrojejunosmy, duodenosmy. ये सवाल तो पूछना नहीं चाहिए ना. Look at the screen, ये तो common sense है. This is the stomach, this is the duodenum. हाँ, गलत लिखा है किताब में. This is the obstruction. So if I do gastrojejunosmy, the bile has to go back in the stomach and then it will go into the jejunum, which is not correct. So what I should do? I should do the obstruction is here. So I should do a duodenosmy so that the bile and food both can go into the food from here. So the treatment is not gastrojejunosmy, treatment is duodenosmy. So if it is misprinting, please correct it. Gastrojejunosmy means the bile has to go back in the stomach and then we're going to causing biliary gastritis. Why one should do gastrojejunosmy? We will do duodenosmy. I hope it's clear. Another compression syndrome is, this is the aorta, this is the crus of diaphragm, and this is the median arcuate ligament. This is the celiac trunk. So sometimes the celiac trunk gets compressed by median arcuate ligament, which is a little lower. And this is called median arcuate ligament syndrome or Dunbar syndrome. So in median arcuate ligament syndrome, the ligament compresses the celiac trunk. Which ligament? Median arcuate ligament. CECT I can show you, but you'll not understand. This is the aorta, this is the superior mesenteric artery, and this is the duodenum going here, getting compressed here. Dysphagia lusoria, this is the aorta, this is the innominate, this is the right subclavian, right common carotid, left common carotid, left subclavian. This is the normal arch of aorta. But sometimes we have right common carotid, left subclavian, and the right subclavian going like this. This artery here is aberrant. So this is an aberration of, it should have come out from here. So this is an aberration of right subclavian artery, which when it compresses the esophagus, causes esophagus compression by right subclavian is called dysphagia lusoria. This is another vascular compression where left common iliac vein is compressed by right common iliac artery. This is called May-Thurner syndrome. So left common iliac vein compression is May-Thurner syndrome. And finally, the bariatric surgery. Restrictive, only remember the images. They ask images and ask what is this and which type is this. In restrictive, this is vertical, where staples applied vertical and a band horizontally. This is called vertical band gastroplasty. Not done nowadays, it's obsolete surgery. But image you remember, this is the new pouch of 10-20 cc which acts like a new stomach. It is restrictive, you have made the stomach smaller. And the weight loss is around 40 to 50%. Not very important, you can skip this, but remember the image. This is called adjustable band gastroplasty, where you see a band connected with a tube to a reservoir, and you can reduce the size, you can tighten and loosen the band by injecting, aspirating the saline through this reservoir. So this is called adjustable band gastroplasty. This is also restrictive. Both are restrictive. The weight loss is 50% of BMI above 40. So here it is 40 to 50% of BMI. Whenever we write the weight loss, it's only BMI above 40. We don't write the total weight loss. So BMI above 40, that's morbid obesity. We do surgery. And here it is 50%. Yes, Mahek. Dysphagia lusoria is not operated if it's an incidental finding. Only if it's symptomatic, then you have to operate it. So it's not a mandatory surgery. Only symptomatic patient needs surgery. And the most, 40 means 40 BMI. BMI above 40. The morbid obesity is BMI above 40. So this angle is important, vertical to band, which is called phi angle. If it is obtuse, this is a slipped band. Slipped band, migrated band is the most common complication. Yeah, you have to remember the percentage of weight loss, expected weight loss. So this is the most common complication. You see this angle is important between the band. Now you see the band is directed downward here, or it's a O sign. These are migrated band. So migrated band is basically most common complication of band gastroscopy, which is not done nowadays. This is the most common surgery done today. Band is restrictive, this is restrictive. All three surgeries are restrictive. This is most common, where we convert the stomach in a tube, 32 French tube, called sleeve gastrectomy. The expected weight loss is 50 to 60% of BMI above 40. The ghrelin is produced by this part. So ghrelin, which is a hunger hormone, is also suppressed. So sleeve gastrectomy leads to 50 to 60% of the weight loss above 40. Most commonly done surgery, and very commonly done today. Very simple surgery. Now this is an ideal combination of restrictive and malabsorptive. And this is restrictive, malabsorptive. This is Roux-en-Y gastric bypass. It's written here, main side effect of sleeve gastrectomy is reflux. So Roux-en-Y gastric bypass is most accepted bariatric surgery. If someone says most accepted bariatric surgery, Roux-en-Y gastric bypass, weight loss is 60% above BMI above 40. Though it's most accepted, but most commonly done is sleeve gastrectomy. And this is a combination restrictive malabsorptive. And the hernia, this is the Roux limb here. I'll use red color. This is the Roux limb. The length you take is 100 to 150 centimeter. Roux limb. And the hernia behind this Roux limb is called Patterson hernia. Angle point in Roux-en-Y gastric bypass I'll draw here. This is the stomach. Now you have applied a band here, making a small pouch. This is the band, and this is the tube. This is the reservoir. This is the angle, vertical with a band. This angle is called phi, P-H-I, phi angle. This should be 45 degree. If it become obtuse, then this is a migrated band. Okay, the direction of the band with the vertical midline. So, this is the Patterson hernia behind the jejunal loop, Roux limb. And this is the most common complication of Roux-en-Y gastric bypass, which is MCQ. These three are predominantly malabsorptive surgery, predominantly. The restrictive part is very limited. So restrictive surgery are three: Roux-en-Y gastric, sleeve gastrectomy, most commonly done, very important. Adjustable band gastroplasty, less commonly done. Vertical band gastroplasty, not done. In band gastroplasty, I told you all three written here, you can go there. Or you can read it. So this is predominantly malabsorptive, rarely restrictive. So how to differentiate biliopancreatic diversion with Roux-en-Y gastric bypass? This stomach is missing here. So here you do distal gastrectomy. While in Roux-en-Y gastric bypass, no part is removed, the whole stomach. I can reverse it if I want. But here I cannot reverse it because the distal stomach is gone. So biliopancreatic diversion is predominantly malabsorptive, done when the BMI is more than 50. Other surgery we do when the BMI is more than 40. Now it's not done, it's obsolete. And very huge weight loss, but equally huge side effect. Protein energy malnutrition is very common here. And the common channel is only 50 centimeter, this length. What is jejunal switch? Again Roux-en-Y, but sleeve gastrectomy. So it is a sleeve gastrectomy with Roux-en-Y called jejunal switch, where the common channel is 100 centimeter. If distal gastrectomy with Roux-en-Y, it is biliopancreatic diversion, and no stomach removed, that's Roux-en-Y gastric bypass. See all three side by side. This is first one, Roux-en-Y gastric bypass, where the stomach is preserved. Second is biliopancreatic diversion, where the stomach has been removed, distal part. And third is duodenal switch, where a sleeve gastrectomy through and by has been done. The common channel here is 50 centimeter. Common channel here is 100 centimeter. And what is SARDS? SARDS is another malabsorptive surgery where no Roux-en-Y is made. This is the stomach. You have made sleeve gastrectomy and then you make Roux-en-Y like this. This is duodenal switch. And this is the sleeve gastrectomy. And you don't make Roux-en-Y. Take the loop up. This is SARDS. So SARDS is without Roux-en-Y. Here. No Roux-en-Y. The loop goes up after sleeve gastrectomy. And the common channel is 250. This channel is 250 centimeter. So here the malabsorption is less. So SARDS is single anastomosis, duodenal ileus sleeve gastrectomy. That's the full form here written. So these are three malabsorptive surgery predominantly. Yeah, all these surgery which are predominantly malabsorptive, like duodenal switch, like BPD, you do prophylactic cholecystectomy. No, we don't do DJ, we do duodenal ileal. This anastomosis here is between duodenum and ileum, not duodenum and jejunum. So this is duodenal ileal anastomosis. Okay? The name itself tells you, SARDI, single anastomosis, duodenal ileal and sleeve gastrectomy. So it's not DJ, it's DI. So that's it. I think some triad. Let's quickly finish triad in 5 minutes. Carnate triad, I'll put red color on the important ones. Carnate triad is very important. Gist, paraganglioma, and pulmonary chondroma. Meckel's triad, less important, has been asked once in PGI. Boerhaave syndrome, pain, vomiting, and surgical emphysema. Portra's triad has been asked once. Gastric volvulus, where you have pain, retching without vomiting. No vomiting is very important. Remember, in volvulus, you don't have vomiting, gastric volvulus, and inability to pass Wright's tube. Murphy's triad, important. Pain, vomiting, fever, appendicitis. Charcot's triad, important. Pain, fever, jaundice, cholangitis. Quincke triad has been asked once, not red but somewhat yellow. It has been asked once. Hemophilia, pain, jaundice, and melena. Tillock's triad, yes, it is important. Asked 3-4 times in last few years. This is mesenteric cyst. The mid-abdominal swelling, mobile only, right angle to root of mesenteric attachment and resonant line over it. Saint's triad, not important. Old triad, not important. Gallstone, hypertension, diverticulosis. Whipple's triad, yes, both of these triads are important for instroma and gastronoma. So these are some important triads which I want you to remember. The red ones are important. Green ones have been asked. Not very important, but have been asked. So I think that's it. I'll stop now. Prophylactic cholecystectomy is done in surgeries which lead to excessive weight loss. And those are biliopancreatic diversion, duodenal switch, and SARDS. So if you have any question you ask, Dr. Gaurav is already here, is waiting. I think you must be wanting some lunch break also, so he'll decide. Chalo, so that's it for today. All the best to all of you. Thank you.